So, good afternoon, everyone. A very warm welcome to all our distinguished speakers, panelists, and the participants joining us today for this special webinar organized by QAI, Center for Accreditation of Health and Social Care, on the occasion of World Patient Safety Day 2025. This year's global theme was patient safety from the start, highlighting the vital importance of ensuring safe care for every newborn and child right from the very beginning of life. Patient safety is not just a healthcare priority. It's a shared responsibility and a collective commitment that impacts individual lives, families, and communities worldwide. So today's session brings eminent experts through leaders, practitioners across the globe who will share their insights, best practices, and strategies to strengthen safety system and foster a culture of safe quality care. Now we'll start with a small video for the introduction of our panelists and our experts. We are truly honored to have such an esteemed panel with us, and I'm sure their expertise will leave us with valuable takeaways to implement in our respective organizations. So, without further ado, let us begin today's session. It's my pleasure to invite our CEO, Dr. B.K. Rana, to share his opening remarks and take over the event.
Thanks, Chandni. Thank you very much for a nice video. Thank you very much for creating this. I welcome everyone, our speakers. I could see Poonam, I could see Amunil Triuna, I could see Somital, Clive, and I guess others have joined. So thank you so much, all of you, to join this. At a very short notice, I won't say much time ahead, but really grateful that you could agree to join this. And we thought to have it pushed little away from 17 September because there are a lot of events around the globe were going on and everyone was busy around those events. And that's why we thought let it give a break, at least a week, and then have something to ignite further the flame which we started on patient safety. So thank you once again, all the speakers, and thanks everyone, the participants, and I can say the speakers from 6 countries and participants also coming from different part of the world. So it makes truly international event. So thank you once again. I would like to take you through some of the glimpse of QAI, what we are doing briefly, and then connect with patient safety, how we work in patient safety domain through the process of accreditation and quality improvement initiative. So just let me share. Okay. Chani, can you confirm if you can see my slide? Okay, great. So thank you again, everyone. So we at QAI started 7 years ago, and we are slowly moving up in different domains of healthcare quality, along with some other areas which I would just briefly bring to you all. So QI is an accreditation body with global recognition, both for our healthcare accreditation program as well as for our laboratory accreditation program. I can say from the program which we have developed over the last 7 years, we cover the whole patient care continuum, starting from pre-hospital care to hospital or healthcare facility care, and then post-hospital care. And also, we are emerging as a specialist accreditation body. And how I say so? I say so because we developed standards which were required at the time when we started in 2017. And so we developed standards for home health care, telehealth, and recently for medical transport organizations, commonly called ambulance service providers. So three standards actually cover the pre-hospital care. Coming to the hospital or facility-based standards, these are the standards which we have developed starting from a single doctor clinic to a tertiary care hospital, and then several other specialized programs like bone marrow transplant, hair transplant, IVF, dialysis, stroke, so on and so forth, including hospitals, obviously. And the program highlighted in yellow color, these are the standards which we developed for the first time in India. And some of these standards also may be globally first time or maybe second in the world. And post hospital care, obviously, telehealth, home health, and ambulance service are common to pre hospital, but another standard is added for transition care, which is commonly known as out of hospital care. And what does they do is basically they provide long term care, long term rehab, and post of care when patient come out the hospital but do not go to home, and they stay in such centers to receive good quality of care. And in addition to these, we also have some standard for social care. Uh, Green healthcare facility actually is a healthcare facility, but the standard for green is not healthcare. It's about environmental sustainability, social care, governance. So it's become more social aspects when we talk about environmental sustainability. And then Vision Center is the minus part of healthcare, I would say, but they are not actually called as healthcare facility. It is a Vision Center where you can go and get your eye tested, and if you need spec, you can get then spec examined and then can refer to a higher centers if you need to. During COVID, we also developed standard for hotels. A couple of hotels use these standards for preventing the spread of COVID infection while their guests were staying there. We recently developed a set of standard for care homes, and these are non-healthcare facilities where the seniors, aging population stays, and they receive a different type of care, including healthcare when they need it. But in addition, there are certain other aspects of entertainment and how a senior can be taken care of in those facilities is actually defined in these standards. So this is all a menu for accreditation standard which we have developed in QAI. We are internationally recognized by ISCO External Evaluation Association as an accreditation organization. We also recognized by Ministry of Health in India for a government health insurance scheme empanelment with financial incentives. We have over 160 accredited healthcare facilities. And then in addition, we are India's second largest accreditation body in laboratory accreditation space after NABL, which is our national body, started 35 years ago. We offer several programs, including medical lab accreditation, biobanking, testing, calibration, and many others. But for healthcare, it's medical laboratories as per ISO 15189 and biobanking as per ISO 20387. And biobanking, we are pioneer. We started first time here in India. And when we started in 2022, we were the third in world after US and China. And we still stand at third place in terms of number of accredited biobanks with us. In this space also, we are internationally recognized by ILAC, which means the test reports issued by QAI accredited laboratories are accepted globally. Over 170 accredited conformity assessment bodies, including testing, calibration, medical, and so on and so forth. We are present in 13 countries as we speak, and we are expecting 2 more countries to be added in next few months, coming from Russia and maybe in some country from Africa. We would be adding to our domain in addition to what we have at the moment. This is our gold seal. We call it mark of sustained quality, which keeps us moving forward. And our accredited organization can use this to demonstrate their accreditation status by QAI. That's about QAI introduction and how we are connected. So most of the standard which we have developed at QAI is related to quality and patient safety. And that's the end basically. When the standards actually drive an organizations through the culture of quality, culture of safety, and not just patient safety, including but also staff safety and visitor safety, whosoever comes to a healthcare facility, whether for treatment or accompany a patient. And just to recap what has happened in the past and why we are here today to celebrate World Patient Safety Day. It was May 2019 when World Health Assembly in 72nd meeting passed the resolutions to establish 17 September every year as a World Patient Safety Day. And that was a momentous occasion for the globe when patient safety was recognized as one of the strongest pillar in healthcare system, which can make a lot of difference in the life of people. And since then, it's going on every year. So first, patient safety was celebrated on 17th September 2019 with the theme of global health priority, with the slogan of "Speak Up for Patient Safety." So people and communities and organizations need to talk about patient safety uh, openly and quite rigorously. The second one was about safe health workers, safe patient, and this was the time when COVID-19 pandemic was in place, and it was recognized that if you don't make your staff safe, they may not be able to deliver the safe care to their patients. So that year was completely dedicated to staff safety or healthcare worker safety. The third one on 21 was Act Now for Safe and Respectful Childbirth for Safe Maternal and Child Care, Newborn Care, which is now actually transitioning to this year's theme of neonate and child care as well. The fourth one was in 2022, recognizing the fact that medication error is the second largest cause of medical errors, and therefore it's very important to recognize that fact. So medication safety was taken as a theme with the slogan of medication without harm. And then the fifth one was elevating the voice of patients, involving patients for their own care. And I'm very happy to say in 2021, actually QI started Patient for Patient Safety Initiative. And just after COVID, and we got it recognized and released by WHO India office, and we started celebrating. And then we went up for 2 years, and then recognized we are not able to do much when we walk alone. So why not collaborate? So we collaborated with a couple of like-minded organizations, including CAHO, and then later recognized that let it be a separate entity. So in 2023, Patient for Patient Safety Foundation was established, and QISU myself is one of the trustee with Mr. Somital is here today with us in chairing this Trust for Patient Safety Foundation, and they are doing a great job. The sixth one in 24 was improving diagnostics safety, because that's again, whether it's a imaging or lab, they are very critical for patient care and there are errors happening. So get it right, make it safe was the slogan for last year, Patient Safety Day. And this year, obviously, everyone knows about it. Safe care for every newborn and every child, with the slogan of patient safety from the start. So it says a newborn getting into the world need to be taken care of, even utmost care in comparison to adults as well. So we have to have systems and processes in place to make sure this group of patients will also be safeguarded for any avoidable harm. So this is a beautiful document coming out of WHO, a global patient safety action plan published in 2021, which is fondly called as a decade of patient safety, which is actually aimed towards eliminating avoidable harm in healthcare. So that's all avoidable. These harms are, most of them are preventable, and why not we should be working toward eliminating these. So let's break the boundaries and join hands and work together for providing healthcare, which is for every patient, every time, and everywhere. I think this should be the target and objectives or goals for everyone, whether organization or individuals, to target everyone around the world every time when we provide care to them. I think with this, I end up my presentation to give you a brief of QAI and linking with patient safety. So thank you very much with this, and we move on to the next session. Chandni? Okay, it's me. Okay, thanks. So, okay, now moving on to the agenda, we have a lineup of excellent speakers today with us. And let's start with the first speaker talking on patient safety and linking it with World Health Organization activities. None other than Triona Fortune, coming from Ireland. This lady is currently the director of Fortune Quality and Accreditation Service, and she was the deputy chief executive officer of ISQA, a long friend of mine for last 20 years, working together with WHO missions on patient safety. She has done many, many missions of WHO and many other international organizations across the globe, helping organizations, ministries of health for setting up the standards for healthcare quality and accreditation. So, floor is all yours, Triona. Thank you.
Thanks, BK. Can everyone hear me okay?
Yes, we can hear
Great.
you.
Thank you. And BK, firstly, thank you for pointing out my age, that we're friends for 20 years. So that just goes to show you. And it has been a lovely friendship, and some of my slides here now are just going to go over some of the programs that you and I both work on in the World Health Organization. So a little bit about patient safety, just to set the scene. And I'm not going to show you all the statistics again because everybody knows them. But what we definitely know is we're harming the people that come to us for care. And a lot of these people are very vulnerable at a time when, you know, they're very low because they're sick and they're looking to us to cure them or to help them, and we're actually harming them when they come for care. We've known this for almost 30 years. We've made some progress, but not enough. It's hard to believe that the first publication of To Err Is Human is, you know, it's almost 30 years old. And looking back on some of the research by David Bates, he did a lit review about 20 years after it to show that we hadn't even made 5% inroads into what To Err Is Human asked us to do. And they asked us to reduce patient safety by 50% in 50 years. So the other thing that we have to learn and we have to stop and think is we're continuing to do the same things and expecting a different result. And what I've definitely learned, my background is very similar to Dr. Rana's. I develop accreditation programs. I continue to develop them all around the world. I'm in 2 countries at the moment. One is very poor and one is very rich. And it just goes to show me and others that there's no one size fits all solution anymore. Countries differ and patients are so complex nowadays. What we know our aim is, one of our aims is we were asked in 2016 by the UN to ensure that everybody had access to care by 2030. So
I'm just stopping you. Are you running the slides?
I am. Can
No,
you
it's
see
not.
them?
They're not going in PPT mode, it's slideshow mode.
They're not going in slideshow mode. Okay.
Just,
So
yes.
can you
I,
see them now?
yes, but I think you click one more time, then it will come. I think
Yeah,
left. Yeah.
you can see. Yeah.
Yeah, I can see both left and right. So we can see all the slides coming on the left as well as a single slide on the right.
Okay. So No. BK, I have to say I don't know why that's happening.
It's okay. I think we can see. You can continue, please. Thank you.
Apologies for that. Technology, I don't really know. I keep continuing because yeah, I'll keep going because it'll take me too long to and I'll be interrupting the other speakers that come along. So now I have to go back. Too early in the morning for me. Apologies, I haven't had enough coffee. But in 2018, there was a big report by the three main organizations, the World Health, the World Bank, and the OECD. And they looked to see how far ahead we were in universal health coverage. And really, we weren't doing enough. There wasn't enough change. And poor quality healthcare wasn't just in lower income countries, but in all income countries. They said about 15% of hospital expenditure in high income countries went on mistakes, and every country had to develop its own pathway towards universal healthcare. And Dr. Tedros in 21, this is a really important point, said that it wasn't just access to care, but access to quality care. I
Sorry,
said,
Sabrina, I'm sorry, your slide's not moving.
okay,
Maybe you can stop sharing and then you can share again, please.
yeah, no problem. What if I
Stick on number 2. It's not 5 now.
all right, so let me try again.
Yeah, you can stop.
Moved on to another computer. I know you can't see me now, but can you see the slides?
It's number 5.
Is that better?
Yes, now it's now a slideshow.
Okay,
Demographics.
okay. Apologies.
Fantastic. Now, thank you.
It's apologies for that, everybody. So hopefully it's okay. I know I'm not up on screen, but you don't need to see me. It's better
It's
that you
okay.
see the
Fine.
slides.
Thanks.
So just to say, the most important thing that Dr. Tedros said in 2021 that is, it's not just access to care, but access to quality care. That's so important. And obviously patient safety is part of that. So what I've learned in 20 years is that it's no one size fits all, as I've said. Like 20 years ago in accreditation, a number of countries were looking to North America or Australia and adapting their accreditation models. But over the last 15 years, definitely countries are now understanding that they actually have to develop their own standards that are culturally Pacific, and also take into account the amount of funding they have, the political stability in the country, and very importantly, the legal system. So another thing that was published by the World Health Organization in 2018 was a national quality policy and strategy document. And this came out of the OECD World Bank report that said every country had to develop its own pathway towards universal health coverage. And this was that quality had to start at the government level and policies had to be put in place. And some of those policies were regulation, licensing, accrediting systems, etc. But it had to go right down along to where patients actually received the care. So it was very much stabilized by what was given at the health service level by the individuals and what the patients want, right up to the policy level. So underneath policy was how actually the service delivery and the management at a regional level, how performance contracts are done, how human workforce planning is done. And that's so important nowadays, right down to governance at the facility level. There's two really good documents that were published in 2018 around a national quality and policy strategy. And then 21, this is something that BK mentioned in his slides, that the World Health Organization from the Geneva office actually published their safety action plan. And it was formed around 6 pillars. Patient and families as partners, so important. Results through collaboration and using data to generate learning. Then evidence into improvement. I read something recently that the gap between theory and actually putting it into practice is about 17 years, which is amazing. Policies again at the government level, and then scientific expertise and patient experience. And then this is what they call their 7x5 matrix, and how the strategies are actually going to be put into place to achieve their plan that was published in 21. And the two things here to me that are really important are for one of the very first times the Geneva office actually recognized that accreditation was part of the solution. And obviously the World Patient Safety Day has been going on for a number of years, and that's something that we're talking about today. So this is the region that both Dr. Rana and I work in for the World Health Organization. You can see there that it contains some of the poorest countries like Somalia and Djibouti, and some of the richest countries. And starting way back in 2009, countries were going to the EMRO office and asking them, how do we start? You know, we don't know how to start on the quality journey. We need standards. We probably need accreditation. And what's happening was, and at the time what was happening was, a lot of the donors were saying that the countries should have accreditation, but maybe some of these poorer countries, accreditation wasn't going to work for them because it was too complicated, it was too costly, etc. So we set about developing standards that could be used as a stepwise approach. And we started off, and we had the first publication in 2009, the second one in 2013, and then the last one in 2019, the third edition. This is specifically for acute care hospitals, and it's like any external evaluation. It has standards that are evidence-based. We encourage people to do a self-assessment. Out of that self-assessment, they come up with their quality improvement program, which links them to evidence-based solutions on the World Health Organization website. Then external evaluation, that's where BK and some of our colleagues come in. We train surveyors, review with recommendations that goes into their quality improvement plan, and then they get an acknowledgement from the EMRO, from the World Health Organization, that they've gone through the process. It's not about the award, but it's about the process. So these standards are spread across 5 domains: leadership and management, person and public involvement, safe evidence-based practice, safe environment, and lifelong learning. And they're divided into critical, core, and developmental. And you can see there that there's 25 critical ones. And what we say is these are spread across the whole 5 domains. we tell hospitals not to start and just do leadership, that you have to do it across the whole system. And I've just marked some of them there that we ask them to do. Ensure the provision of sufficient numbers of competent staff is one of them. Patient identification is another one. Safe childbirth, which is very relevant for this year's Patient Safety Day, is so important. Guidelines around hazardous waste, that's in the environment, and then orientation for staff. So you can see that I'm sure a lot of the programs that you're familiar with have those critical criteria as well. And the great thing about this program is it's free. It's up on the website. Anyone can take it down and download it. You don't have to have an external evaluation done, even if you do the self-assessment. So this is just one example of one of the standards in the leadership and management. You can see the critical one there is that's the priority area is a recognized corporate and clinical governance system. The core one, which we encourage them to do after the critical, it's around this, that they acknowledge and do something around World Patient Safety Day and World Hand Hygiene Day, which is the 5th of May. And then the developmental is that within their strategic plan, they have patient safety mentioned. So Dr. Rana has already mentioned the themes of the previous days. I just want to highlight here health worker safety, which is so important. Health workers are leaving the profession now in droves, and it used to be in my time, I was a nurse, we left to go to Saudi Arabia or Australia because we could earn more money. Now people are leaving the healthcare profession, nurses, doctors, into other professions because they're so burnt out. And COVID was one of those things that really, really induced a lot of stress around them. So that's why the World Patient Safety Day in 2020 and it went into 21 during COVID was all around health workers. So patient safety, it's probably the wrong term. It should be patient and staff safety. We need to look after our staff. We need to try and prevent injuries. We need to prevent violence against them in the workplace and reduce work-related stress. So of those 5 goals in 2020, the UN also published these. They're very simple, one pager. This is around work-related stress. For the first time, it's not a huge report out of the Geneva office. It's a very, very user-friendly, why you should do it, the things that you should do, and how you're going to measure it. So success in this particular program for us is measured through spread. We started out in 2011 in Egypt. You can see there, Pakistan, Sudan, etc. 2019, we were in Iran, Afghanistan, and some of the richer countries like Oman and Saudi Arabia. 2 years ago, the United Arab Emirates took up this program, and this year I'm very happy to say I'm working with Ethiopia. They indeed are going to develop accreditation, but they've started with this program. And one of the things they're working on at the moment is actually patient identification. So I'm conscious now of time. I just want to, and I'm sorry again for my slides at the beginning. We published then these standards for primary healthcare in 2022, which is great. And Pakistan are using these today. So the conclusion is stop doing things the same way and expecting different results. Please start. Don't be afraid of it. Start, even if it's only a small start. It doesn't require money. These programs are up online. No one size fits all. Technology is going to be important, but remember, we need governance around it. And this is something that I robbed from Dr. Rana a long time ago, but it just goes to show you we can learn from each other. But it's so important. This is my main slide. We have to put the patient at the center of everything we do. And if we continuously think about the patient. I always think about my brother in this, and I want healthcare staff to treat him the way I'd treat him myself. So apologies again for the technical issues at the beginning. And BK, thank you for inviting me today to share.
Thanks very much, Chiona. Thank you so much for give a glimpse of what's going on around the world in patient safety. It's really lovely, as always, to hear you. Thanks once again for taking time out. I know you told me that you were to go, so thank you so
Yeah,
much.
apologies I can't be with you for the day, but it looks like a really interesting group, and see you soon. God bless. Bye-bye.
Thanks, Chiona. Okay, moving on to the next topic on patient safety, and infection prevention and control is one of the critical component of patient safety. And for that, an excellent speaker lined up for you all, Dr. Sanjeev Singh, smiling man. He's a group medical director of Amrita Institute of Health Sciences in Faridabad, and also he takes care of the older center in Kerala. And in addition to this regular hat, he is an expert for quality and infection prevention, particularly driving the antimicrobial stewardship, not only India, but many parts of the world. It's always a pleasure to listen to you, Dr. Sanjeev. Floor is all yours. Thank you.
Fantastic. Very good. Thank you so much, Dr. BK Rana, sir. I am so very impressed. I don't know what you do on a daily basis, but single-handedly you have run. I just can't imagine an accreditation institute being run, and you're always there across the globe. We are just managing one part of Faridabad, and a small institution that also is unable to manage. But fantastic. Thank you so much for inviting, and great to organize such a good workshop. It was great to listen to Treona, and I would be speaking on future-proofing of the hospitals for infection prevention and AMR, antimicrobial resistance. So good practices are important, and then that is what they control outcomes as well as the cost. So Joseph Joran is one of the quality gurus who basically said that there is a cost for poor quality, because it's very important that all good practices for preventing infection should be managed. If we don't, there is a cost to it. And I'll try and showcase some of these cost and cost factors, because there's a cost to the laundry, there's a cost to CSSD, there's a cost to selection of disinfectant, there's a cost to infections, there's a cost to antibiotic use. And if you do good work, evidence-based work, that could be sort of avoided. Now, with each expenditure, there is 2.3 million people who go below poverty line in India, because healthcare cost is rising, and 45% of the bill belongs to biomedical and biomedical related equipment, and it becomes extremely difficult to sort of salvage that portion. So fortunately, out-of-pocket expenditure is decreasing, and that would be a good way that the country is showing progress other than some of the key performing indicators. We have seen the devastating effect of COVID pandemic. The next pandemic, which is there on the pipeline, is antimicrobial resistance, and there will be at least 50 million deaths. There will be at least $1 trillion of expenditure in GDP. That would be close to at least 18 countries' GDP. And if you don't pull up our socks, if you don't work together, there'll be deaths, there'll be morbidities, there'll be cost of care, and that'll be disaster. And if you look at the high income countries as well as low middle income countries, all of them have their particular issues with respect to antimicrobial resistance. Unfortunately, it's a global and a public health agenda, because you cannot just restrict to a particular location. The microorganisms do travel across the boundaries. So are there any good case studies to be able to reflect what we can sort of deliver? So if we have a good hand hygiene program, infection rates can decrease by 30%. If we have a good bundle care, and these are all examples, published examples from Indian hospitals also. If you have a good bundle care for bloodstream infections, for ventilator-associated surgical site, all of it shows phenomenal impact. So, how does the Indian cost looks like as comparison to US? So, a healthcare associated infection is close to 3 to 4 lakhs, and I'll show you some of these examples within our hospital. And globally, it is almost 1 rupee is equal to a dollar, and that's pretty heavy because that's almost 82 times higher. And that is where the high income countries will have a greater impact and a disaster. So the length of stay within India is 7 days for each healthcare associated infection. For globally, it is 10 to 15 days. And then there are direct and indirect benefits. So return of investment of anything what you do would be 1:10 with respect to US and other countries, which would be 1:23. So important factor here is we generally give irrational prescriptions because we don't believe that there is good infection prevention practices. And that is where we pump in 2 gram negatives and a gram positive and a broad spectrum and antifungal. And that is where we go completely wrong. And so rational prescriptions are very critical, and it should not be dependent because we are in India. It is believed to be full of infections. And that's not true because the definition of diabetes remains the same across globally. Definition of hypertension remains the same across globally. Definition of infection would also remain the same. So, but there are social costs and then there are benefits, and it is important that because when we built this hospital, we are pretty new in our setup with 3 years of experience, getting all trained faculty and staffing. But we realized that from almost 1 month onwards, we were getting multi-drug resistant organism and pan-drug resistant organism. And that shows that unfortunately it has gone beyond quaternary care hospitals. It is there in the community. We have almost lost our battle in most of the medical ICUs and tertiary care ICUs in India, and we need to go back to the secondary care hospitals and improve those. So there are challenges, and challenges are because of population, clinical cost, outcomes, and perspective. So this is what NABH basically guides us, and it's a chapter 5 which talks about infection prevention. It talks about having pathways and having rational practices. And everybody needs to participate. It's a multidisciplinary participation, multimodal approach, which would be critical. Now, all of this is important as prevention, and it is not that we need to react to any infections which happens. Hand hygiene, medical asepsis, surgical asepsis, bundle care is all the preventive aspect. I'll just touch upon the economics of it. This is the work which we published almost 1.5 decades back. All good evidence shows that hand hygiene prevents infection. It's a level 1, level 2 evidence. Cost effectiveness in our hospital, a surgical site infection, patients pays close to 52,000 extra. So this is close to a decade back. Now it will be close to 1 lakh. And that is what we showed in our study. A ventilator associated pneumonia. Now this is because it's a healthcare associated where you and me are party to it, along with the surfaces of the hospital, is 61,000. So now it would be close to 1.4 lakhs. And that is the additional expense which the patient has to pay because of us. How do we calculate it? Because there are direct costs which comes from this bill. There are indirect costs of the patient losing job days, and then there are opportunity costs. So we did a before and after intervention, and just for surgical site infection, the cost save was close to 21 lakhs. Only teaching people to do proper hand hygiene, and that would be for the faculty, for staff, for perfusionist, OT technician, anesthesia technician, ICU, and just going back to basics has phenomenal impact. There is a huge opportunity cost because you save beds, you save morbid conditions, you save mortality. You are able to do almost 80 surgeries, and that is an 84 lakh of additional income. So good practices would lead to good outcomes and good bottom line. So we invested close to $1 on training. That was 666 rupees. And return of investment was 236 times. And that is just phenomenal because that is just going back to good asepsis, good disinfection, good preventive mechanism. And that is the saving. So when we started this, we only had one infection control nurse. And post that, we now have 8 infection control nurses with us, which tallies to the bed to infection control ratio. So it is very important to do these calculations and show it to the management where it is the cost benefit and cost effective works. There is a cost to bad will too, because if it doesn't work, as Peter Drucker said, one positive person speaks to 9, one negative person speaks to 41. So there is a huge cost of bad will, and it is primarily because of infection, because that's one of the end stage. Now let's look at the support services. So there are disinfectants, there are alcohol hand rubs, and there are multiple CSSD polyenzymes which are used. But then we need to very cleverly choose it, because whenever I also go on round, I realize that high level of disinfectants are being used at all levels, and that's a cost, and the patient unfortunately bears that cost. So many areas within the hospital can be a sodium hypochlorite, which is just 30 rupees, and a high level of disinfection, which is peracetic, hydrogen peroxide, or OPA, is close to 1,000 rupees. So carefully selecting disinfectant can reduce cost. Environmental cleaning, so just cleaning of good floors and do a good disinfection, is close to 200 rupees per bed per day. So there is a cost to it, and it is important that the public who comes to the hospital are adequately trained, and the healthcare providers do appropriate selections and appropriate mechanism of doing the disinfection, because it is 200 rupees per bed per day. Cost to laundry, the linen which you do a deep cleaning, and it goes through its own disinfection process, is close to 20 rupees per linen piece. So any scrubs, any bed sheets, any soiled linen, there is a cost to it. So it cannot be just taken lightly, and that is where it making or equating it to a rupee term is very, very critical. Now, you cannot have autoclave sets opening up because you didn't find one good retractor in a set and you have opened up 4 sets, or else you have not sort of segregated and run a full steam cycle. So a steam autoclave cycle is close to 500 per cycle, and plasma would be close to 3,000 rupees. And that is where these cartridge and use optimal optimization, and appropriate training is extremely critical. And these costs is what the patient has to pay, because most of it is borne by the as a cost per unit. Now we keep training, and we realize that it has very less impact because the behavior doesn't change. So we used a tool called sociogram, an ethnographic tool, where we shadowed the doctors to understand what exactly they communicate. Each doctor believes he's the best communicator in the world. When we tracked his level of communication by various color, we realize that it is very hierarchical in nature. Once the senior doctor speaks, and he is speaking mostly to the carer and less to the patient. It's a Western concept of having patient centricity. In India, it is a carer and then patient centric hospitals. And we also realize that he is hardly, once the antibiotic gets started, nobody stops it because they don't want to take a risk. So there is no communication, and there's no communication for prevention of infection. And that is where the behavioral change is extremely critical. Inside the theater, we also track the conversation which happens between the anesthesia and surgical team. They can talk as in depth about the new movie or the new series which has come in Netflix, but they have never talked about surgical antibiotic prophylaxis which has happened, and we have tracked that for almost 6 months in our study. So there is a lot of importance which needs to be given. This is our hospital. We have published in Annals of Surgical Medicine, and each operation theater should have minimum of 6 people, and the door should be only open 2 to 3 times. In some of these operation theater, the doors were open 45 times. It is only because of the casual behavior that the people come in and come out for any damn thing. And the preparation to do and maintain a good sanctum sanctorum, or not disturb the turbulence within the surgical unit, is very, very critical. So we worked with the state government. We have worked almost for 10 years with the government of Kerala. And we got all the professional societies together. We released clinical guidelines. We released strategic action plan, because we realized that in the hospital, you're left with only few antibiotics, few antimicrobial. You have to work with government to scale up and work at district hospitals. And now it is important that it should be future proof. So when you start an antibiotic, you send a culture, it takes 48 to 72 hours. Can we develop a point of care testing? And within half an hour, you have an organism and you give a very targeted. So world is moving towards it. We at our center is also developing many point of care testing. If everything goes on well with IIT Delhi and IIT Jodhpur, everything goes on well, we would have something by the by the mid of the next year. It is important that the clinical decision support system works within the hospital, because you have to always select as per your antibiogram and as per your antibiotic policy, so that everybody from the junior resident till the faculty and principal consultant, it is always rational and targeted. It is right now, everybody gets 1 gram TDS meropenem. We don't know whether it is precise, because if you are coming with a kidney disease, it could be 1.2 gram TDS. And if you're coming with a liver disease, it could be 0.8. So we are right now working on precision medicine. Can we calibrate and do a personalized medicine treatment rather than every damn person who comes in gets a 1 gram TDS medicines? So I'll skip this. What we want is basically always look at evidence, because unfortunately we look at experience and we believe that is the science which we want to practice. Antibiotic use, I know my time is up, so I'll just skip most of the slides. There's a Donabedian model. You need to have a structure, process, and outcome for good rational practices. You can definitely work on some of these process measurables, which would be very critical. When you work on these, the length of stays come down and mortality comes down. And so I am told in many of the forums, the leaders don't want to have stewardship practice because they want more pharmacy to be sold. And I'm saying that if your average length of revenue per operating bed is 49-50,000, and if you're saving 1 day, and if you have close to 150, 200 patient days, that itself is much more than enough. You are doing good practice, your return of investment is higher, and then the patient satisfaction and evidence-based practice is good. So even for stewardship, we have saved close to 2.3 crores, and the saving, and this basically because of out of pocket, the advantage goes to the patient. Antibiotic prophylaxis, my last slide. One of our cardiovascular thoracic surgeon, you always used to say he is dealing with very high risk VIP patients and he cannot take risk. So he was giving 3 antibiotics before starting off of the surgery: meropenem, amikacin, linezolid. We tracked his surgical site infection. We worked with another cardiovascular thoracic surgeon in another unit. He said, I'll only practice evidence-based medicine. He used to give only cefuroxime, and we also tracked his surgical site infection. So it is a misnomer of giving more antibiotic will reduce infection, and that you are always dealing with high risk, so you have to pump in antibiotic. So it is very important to do data collection, work on facts, and also keep sharing with the team. So I'll end here, and practices should support clinical evidence. Cost is an important factor. Good practices, personalized and precise medicine could be an approach, but what works best is multimodality. So thank you so much, Dr. Rana. It is always a pleasure to be with you and to share platform with you. Thank you so much for this opportunity.
Thank you, Sanjeev. Thank you so much. Always, as always, a pleasure to listen to you. And couple of slides really scare not only me. I think all the audience here is one of the microbial slide, I would say, waiting for the next pandemic. And the GDP of several countries will spur on that. But I think it's point in right time that quality costs, but poor quality cost more. And that cost is not just in economics, but in terms of lives of precious life of people. So I think that's very, very important. And as always, your slides are backed up by evidence. We talk about evidence-based medicine. Your slides talked about evidence-based statistics of your own hospitals and challenging other. I'm surprised why not other hospitals just borrow these things and start using in their organization. But I think that cost benefit using a pharmacy, making more money than reducing the length of stay for the patient, gives benefits. So I think it may take time, but we have to start. Otherwise, we'll not have any antibiotics left, which will treat any small infection. So thank you, Sanjeev, as always. Really pleasure to hear you out. Thank you so much.
Thank you, sir.
Moving on to the next presenter, I would call upon Dr. Poonam. She's going to talk about quality improvement in maternal child health. And she comes from NHS, National Health Service UK, and having several other heads, including advisor to IHI USA and many other international NGOs on quality and improvement, including working in India. I think she's going to present her study and involvement in the state of Bihar in India. Over to you, Poonam. Thank you.
Yeah, thank you so much. Yeah, that was such a great presentations today, and I'm really inspired a lot about it. Thank you so much, first of all. So good morning from UK, because it's morning here, and it's such an honor to join you today on World Patient Safety Day, this webinar. And this year's theme, Safer Care for Every Newborn and Child, I think it speaks to the very heart why we work in healthcare. And my previous two presenters, their presentations and the fact, it was so inspiring, like, yeah, why we are working on quality improvement, why we talk about patient safety, why it is important. So that's really, thank you so much for giving me an opportunity to present here. So my slide. Okay. For this year's theme, every child has the right to safe, quality healthcare from the very beginning, from pregnancy to birth to childhood. Safety is not optional. I think it is a right. It is a right for every newborn, for every mother to have that kind of, to expect that safe and reliable and compassionate care. But why this matters, why we are talking about this thing today, why it matters and why this is important, or maybe why this is a theme for the Patient Safety Day. So I'm sure that everyone will agree here with me that newborns and children, they are among the most vulnerable members of our communities. In the neonatal period, it carries the highest risk of preventable harm. A single error, whether it is medication miscalculation, an infection, or maybe a simple unsafe procedure, it can have a lifelong consequences for both the children and the family. So that is the reason why this matters, why we are talking about today on this topic, and why we should focus more on a newborn and children. But the question is, when the things go wrong, where does the blame lie? So the question is very simple, but it is urgent. How do we create a health system where every newborn and every child, they receive safe, reliable, and compassionate care? We know that children, they are not just small adults. They require tailored system of safety, weight-based drug dosing, infection prevention, procedures adapted to their physiology. But beyond all these types of technical safeguards, culture plays a defining role. When harm happens, do we search for someone to blame, or do we really search for root causes in the system? And when any mishap it occurs, the most important question is not who is at fault. This is not important. But what are the chances that next time this mishap will not occur if we will change the system? Or what are the chances that this will happen again if we do not change the system? So I think this is very important when we see the harms are happening. It is not blame culture. It is not the person, but it is the system where the changes are required. So let me share my experience with the Continuous Quality Improvement Collaborative in Bihar, where we worked. I worked in this collaborative for maternal and child health for newborn. And I'll share my experience from this collaborative and what are the things and how we try to use quality improvement methods to improve the safer newborn care and safer care practices for the mothers as well. So this continuous quality improvement collaborative, it was a collaboration between Government of Bihar, Care India, Institute for Healthcare Improvement, and it was funded by Bill and Melinda Gates Foundation. So basically, we worked on this to improve the care provided to women during labor, and we included the secondary level district hospitals in Bihar at first phase. So patient safety for newborn, it doesn't begin at birth. It starts right from the antenatal period with safe pregnancy care. So if we'll provide safe pregnancy care to mothers, timely identification of risk, and support for mothers, so that is the place, or that is the time when really patient safety starts before the birth. So in my opinion, protecting the mother is the very first step in protecting the child. And that's what we tried to achieve through this collaborative. So I'll just give you a brief idea how busy these hospitals were when we started this collaborative. So the district hospitals, they were conducting like 600 to 1200 deliveries per month. They were really busy. So during this during this collaborative, we tried to create a learning network between these participating hospitals so that they can learn from each other the best practices, and relevant practices can be scaled up. So the very first phase, which was called as Ek Choti Si Pehal, it was started in 10 district hospitals. It was the aims were really ambitious. We started working on reducing birth asphyxia, decreasing stillbirth, and improving indicated cesarean section rates. These were the initial aims for phase 1. In phase 1, the results were promising. It gave us more confidence and more like even the interest from other hospitals to scale it up. So in second phase of this work, 10 more hospitals have been added. So total 15 hospitals. And then this time, again, the aims were more ambitious than the first phase. We focused on managing pregnancy complications, increasing the indicated cesarean sections, safe cesarean sections, improving blood transfusion practices. That was one of the most important part. And detecting the weak newborns in early stage so that they can get the care which was required, and we can save them. So those are the ambitious aim for phase 2. So what was the achievement for this phase 2? Through this journey, there were several achievements, those were stood out. But for me, one which was really important was building a learning community of these hospitals, where they share data with each other, they shared the solutions, they talk to each other. Okay, these practices, they are really working in our setting if you want to try, or if you are struggling with this indicator or this issue, these are the things what we tried. So you can have a look into this. So building a community of hospitals, improving the life-saving procedures like newborn resuscitation, early breastfeeding, essential newborn care. They were very, very important in providing safe and effective care to the newborns. And then strengthening the leadership and frontline improvement skills at every level, whether it is block level, district level, or state level. We tried to engage leadership and frontline staff at each and every level. One of the important part in this one, so this 15 hospitals in different districts, we call this as inter-district collaborative. One of the district out of this name was Gopalganj. They really have had very good leadership engagement and good QI knowledge. So we tried to create one intra-district collaborative where one district hospital with 13 PSCs. So together, the 14 blocks of Gopalganj, we tried to create a referral linkage network. And that was really a good success we achieved in that one. So it is just an example how sort of hub and spoke model, how we can disseminate the learning or scale up improvement initiative on a larger or bigger scale. So what happened in the third phase? So the third phase, by phase 3, the program reached to all the district hospital, 36 district hospital and 2 sub-district hospital, all the state in Bihar. But this time our vision was very clear. We wanted to build capability for continuous improvement, use data to drive the change, as it was mentioned in Dr. Sanjeev's presentation, how powerful the data is. So we tried to create something similar and foster the teamwork across every level in the organization, whether doctors, nurses, managers, admin. So we tried to create that kind of learning network. This experience taught us a lot of lessons. One of the most important was that even in resource limited settings, with the right methods, ownership, peer learning, safer care is not just possible, it is very much achievable. We can definitely achieve that if we are using the right methods. So what was the goals and objectives in phase 3? So apart from phase 1 and phase 2, we tried to scale up our QI management skills, leadership, data-driven decision-making for continuous improvement. This were the aim. And again, for quality improvement capabilities, I'm going to present in some of my slides how we did the quality improvement capability on this kind of scale where 38 districts are involved, and to develop a team or collaborative approach. These were our aims for phase 3. Now, the question is, there is no shortage of knowledge about what to do, and I'm sure that everyone will agree with me here. We have a lot of guidelines, policies, procedures. So this is not about shortage of knowledge about what to do, but this is about how to do it. So from moving from what to how, bringing these 2 types of knowledge together, that's where the linking, the gap exists and how to fill that gap. So we do have evidence-based subject matter knowledge by policies, protocols, guidelines. And second thing, what we have through QI, we have implementation knowledge. We know that like how to change the performance of a system using QI work or using QI method, and how we can lead and scale up those changes, manage those changes. These 2 things together, if we try to manage, then definitely we can improve the performance. And this was the highlight of our phase 3 work when we tried to scale up to all 38 districts. And that's the dosing approach what we used. And I'm sure that many of you might have seen my expert speakers and other audiences in this call. So this is where we understood that not every person in the organization, they don't need the same exposure of QI knowledge. So it is based on their level in the system, what is their role in the system. Based on that, we can use our QI science and QI principles to teach them so that we can get the best practices. And that's how the whole collaborative was planned. We planned several learning sessions, like, for example, basics for frontline people, and then QI for leaders, QI quality improvement leadership management, then QI for senior leaders and quality improvement coaches. So through this, we trained, I think, 200 plus staff members to drive this collaborative. And then again, it wasn't based like from nowhere. We used WHO Health System View for improving quality for women and newborn children. This was leadership, action, learning, and accountability framework. This was the framework which was used to bring all the work together and connect the dots. So at the center of everything, another view of WHO framework, at the center of leadership, action, and learning, there lies accountability. And it is not an isolated or separate component. I think it is core of every organization's ability to succeed. And again, I'm not talking about blame culture. I'm talking about accountability. Accountability of patient safety, accountability of safer care. So that is the main core component of this work. And then what we did, we tried to convert all of our learnings from this 38 district and convert it into a change package. where if, after the collaborative, when it is finished, if someone wants to know, okay, we are still struggling with cesarean section rates and all, other district, they did that. Do you want to learn from them? So we have a change package. No need to reinvent the wheel. No need to start from the beginning. Go and try to do and customize some of these ideas, and maybe you will be able to achieve good outcomes. Key achievements: improved cesarean section blood transfusion rates, increased detection of birth asphyxia, maternal anemia, improvement in essential newborn care, early initiation of breastfeeding, clean practices in labor room, better reporting, monitoring of complications, and then change package so that it can be scalable across the state. My learning from Bihar and beyond, wherever I work in other parts of the world, 4 key lessons. Local ownership is critical. Changes cannot be imposed, it must be owned. Data visibility, it drives action. What gets measured will get improved. Peer learning, it accelerates improvement. Teams thrive when they learn from each other. And even in limited resources setting, quality improvement methods, they empower staff and deliver safer care. So I'll end my slides with this picture. This is a picture very, very close to my heart. This is my son, my younger son, when he was born. Now he's a very smart teenager. But when he was born, looking at him then, it was so fragile and full of promises, reminded me of what every patient, every parent, they feel in the moment. Hope, love, and the belief that their child will be safe and cared for. So every child, everywhere, they deserve nothing less than the best care. Thank you. Thank you so much.
Thank you, Poonam. Thank you so much for your words of wisdom around state of Bihar, which is considered as one of the poorest and less privileged healthcare system in India. And I'm sure that there will be a lot of learnings around this project, which you will drive across for other states as well to implement, particularly C-sections and transfusion reactions and transfusion-related infections, not because of testing blood properly or not checking the compatibility and leading to several issues in a mother who is expecting to deliver a baby. So thank you so much for the learnings share. I'm sure the participant get enriched, and I think that's very important for public health perspective. We talk about a lot of tertiary care hospitals, curative and all, but public health issues around are there, and taking care of public health facilities as well. So makes a lot of sense to strengthen the healthcare system in specific countries. So thank you so much, Poonam, for your presentation and your presence in this webinar.
Thank
Moving
you
on
for
to the
having me,
next, I
sir.
would like to invite Dr. Aminul Hassan, who is going to talk about patient safety, what's going on in Bangladesh. He's a former director of health in Ministry of Health from Bangladesh. He's a founder of Quality Care Concern in Bangladesh, and he's very active in Bangladesh for driving quality improvement projects. So the floor is yours, Aminul. Thank you. You are muted, Aminul. You can unmute yourself, please. Thank you.
Okay. Good afternoon. First, I would like to thank Rana and QIA to invite me in this very important session. And a long time we are not meeting. Hopefully, we'll be able to meet in Square in coming second week of October. Yeah, Rana? Hopefully. Okay. So, I would like to talk about the patient safety. Okay. Okay. So, first, I would like to focus, before starting my presentation, I would like to talk 3 areas. One is patient safety, second, children's vulnerability, and third is global relevance. So, we know that at the core of the patient safety means the protecting patient from harm while they are receiving healthcare. And regarding children vulnerability, unlike adults, children can't speak up or understand treatment risks, dosing error, unsafe surgery, and poor infection control disproportionately harm them. That's why pediatric patient safety requires special attention. And other is global relevance. World Patient Safety Day reminds us that safety is not optional. It's a basic right. The global theme highlights the importance of engaging patients and families in safety. In Bangladesh, involving parents in the safety process is especially critical. So, I would like to share some context in Bangladesh health system. So, first, I would like to focus on public versus private sector. In Bangladesh, you know that most of the children rely on the public sector for care. We have community clinic, we have some Upazila health complex, who is situated in the sub-district level, are often the first point of contact of care. And large hospital mostly situated in the district level and above. So these are act as the referral center of the health system. And the private sector is expanding, but remains urban centered closely and costly, creating equity of challenges. So regarding key statistics, that the children under 15 years, if you see that the 30% of Bangladesh's whole population, if the population is around the 170 million, the 30% of the under 15 years. So the country has made progress. For example, child mortality has fallen dramatically, largely due to immunization, nutrition program, and safe delivery practice. However, children still make the majority of the hospital visit. And the system challenge is that despite progress, resource still remains stressed. There are too few trained pediatricians, especially the outside clinic, and tertiary hospital face hugely overcrowding. And specialized care like pediatric ICU is extremely limited. Safety protocol exist but are not uniformly practiced, which increases the risks of child parents. Regarding some key challenges in child patient safety, if we focus on the medication error, children require weight-based dosing, but busy hospital often lack of the system to ensure precise calculation. Mislabeling, look-alike packaging, and incorrect administration by untrained staff increases this risk. Number 2, infection prevention and control. Hospital-acquired infection are a major issue. Overcrowded wards, limited hand hygiene practice, and shortage of sterilization supplies mean children, especially newborn, faces serious risk situation. Number 3, lack of child-friendly facilities. You see, while Bangladesh has made progress in expanding child health services, most hospitals are not child-friendly. Pediatric ICU are scarce, equipment is often shared, and waiting areas are not designed with children in mind. This makes both treatment and recovery harder. And regarding caregiver awareness, parents play a vital role in patient safety, yet many don't recognize medication error, hygiene lapse, or early warning sign of complication. There is limited culture of involving families in safety monitoring. Regarding national initiative, I would like to focus some initiative. First, we have a commitment for achieving the goal of universal health coverage. The government of Bangladesh has made universal health coverage a cornerstone of its health strategy. For children, this means scaling up community clinics and maternal child health services so that no child is denied safe care because of cost or distance. And this is directly linked to patient safety. Second, national patient safety strategy. Bangladesh is working on developing a national patient safety strategy taking the guidance from WHO Global Patient Safety Action Plan 2021 to 2030. Some hospitals have piloted protocol like surgical safety checklist and incident reporting, though scaling this to rural areas remains still a challenge. Regarding WHO collaboration, Bangladesh collaborates with WHO in several child safety areas. For example, Safe Surgery Checklist Project, hospitals are adopting standard checklists to minimize the surgical risks. The EPI program has ensured safe immunization nationwide, protecting millions of children from preventing diseases. WHO also support healthcare workers training in infection prevention and neonatal safety practices. Regarding hospital and community practices, in tertiary care hospital, like our big hospital, Dhaka Medical College Hospital and Shishu Hospital and our medical university, we now see the structured safety protocol, surgical safety checklist, proper hand hygienic station, and medication labeling have started to reduce risks. National NICU are also adopting modern monitoring system to protect vulnerable newborn. Regarding training, nurses and junior doctors are the backbone of our hospital service delivery for child care. Many hospitals now include short courses on safe drug administration, infection prevention, emergency responses, and in some hospitals, simulation-based learning is being used to reduce errors before staff interact and real patient. Regarding community practices, community health workers are vital in Bangladesh safety net. They ensure vaccines are delivered safely, encourage hygiene practice, and guide patient when to seek higher level care. And this is also crucial in rural and hard to reach areas. Regarding the role of NGOs, there are a lot of non-governmental organizations plays a big role in filling the gap. Our BRAC and ICTW know that the two are the big non-governmental organizations, not only delivering the services, but also run champion to raise the parental awareness. Save the Children works on child protection earlier. Now it has all activities has closed due to suspension of the USAID, and patient safety education, which helping communities to recognize the risks of demand safer care. I would like to focus some case example in ICDRB. They have introduced strict infection control protocol in neonatal wards, and why the hospital acquired infection has dramatically reduced by 30% in the pilot units. There is another example in Dhaka Medical College Hospital. They are implemented medication safety protocol and using the WHO surgical checklist. And another example is the EPI program, which ensures the safe vaccine and storage delivery, over 90% coverage, millions of children protected from preventable diseases. Regarding progress and achievement, regarding child mortality, you know, the Bangladesh has achieved remarkable progress. In 1990s, child death were among the highest globally, but though consistent investment in maternal child health and under 5 mortality rate has dropped over 80%. This is one of the most significant public health successes in Southeast Asia. Regarding immunization and delivery practices, you know that our EPI program has ensured high vaccine coverage, preventing millions of deaths. At the same time, efforts to promote skill but attendant emergency obstetric care and safe neonatal practice have created a safer start for children. And digital health piloting, we have already adoption of the electronic health record in some selected hospital. Digital, we have started some selected hospital in digital prescribing, which is reducing the dramatically medical errors, medication errors, and data system enabling better tracking for health outcome, which is working in some selected hospitals. Regarding gaps and challenges, resource limitation is one of the major gaps in rural hospital. That's why the lack of pediatric ICU equipment and trained staff, overcrowding and uneven distribution of services. And under-reporting of incident is one of the major challenges. Few formal system for reporting errors in adverse event, and there is still fears of blame, discourage staff for reporting misses. These are one of the key challenges, why the incident is still under-reporting. Regarding safety culture and accountability, limited integration still in the patient safety and into the routine hospital practices. Still, there is some weak monitoring and evaluation system. Regarding family engagement, parent are often excluded from the safety discussion. This is one of the key challenges, and this is one of the communication failure in our service delivery, I think. And still, there is a need for caregiver empowerment in decision making and monitoring. We are piloting in some hospital how to empower the caregiver in regard to decision making and monitoring activities. Last slide, my way forward. So definitely, we have to need some policies, training, digital tools, partnership, and caregiver rules might be strengthened. So we are still working on the updated for national patient safety strategy. We are focusing on our regular training and capacity development of the doctor, nurse, and community workers. We are trying to scale up the e-prescription to reduce the dosing error and introduce barcoding of medicine and electronic health record. We have started strong partnership and strong collaboration between government, non-government organization, and WHO. And still there is a leverage international support for funding and technical guidance. And we are trying to educate parents on medication safety, hygiene, and warning sign, which will promote the caregiver participation in safety checklist and care planning. And finally, I would like to say that the patient safety as a right. Healthcare is not only about treating illness, it is about protecting people from harm. Safe care is every child's right, not a privilege. Process and gaps, Bangladesh has made remarkable progress in reducing child mortality, expanding immunization, and piloting safety practices, yet children are still vulnerable, especially in rural areas. And finally, call to action. No single group can achieve child patient safety alone. It requires commitment from government, commitment from hospital and health worker and other development partner and NGOs. Together we can create a culture where every child receives care that is safe, respectful, and free from preventable harm. Thank you for patient sharing.
Thank you, Aminal. Thank you very much for bringing us quite close to Bangladesh, what's happening in healthcare, particularly in child health and patient safety. So thank you very much and congratulations for wonderful you are doing in driving the quality in healthcare in Bangladesh. Look forward to working with you soon, sometime. Thank you so
Definitely. Thank
much.
you.
Thank you,
Thank
Aminal.
you.
Moving on to the agenda. Primum non nocere, first do no harm. It's a very old saying since the medicine started and practitioners started practicing. And we have a speaker called Dr. Clive Fernandez, a great speaker on quality and accreditation, bringing a lot of quality insights on the table. Currently, he is the Director Quality of Burjeel Medical City in Abu Dhabi. And from just few months, and before that, he was the Group COO and Medical Director of Wockhardt Group of Hospitals. And I think JCI consultant for more than 15 years, if I'm not wrong. And also the member of QAI Accreditation Committee. Thank you, Clive, for joining. I know back-to-back meetings you just informed. So over to you. Floor is all yours. Thank you.
So, thank you. Thank you. Good afternoon to everyone. And Dr. Anna, not 15 years, now it is 19 years and counting to JCI. But
19
that's
years.
just a number. That's just a number. So
Great.
you can just see one slide of mine, or we are seeing both?
Yeah, both. It's not on
Okay.
slideshow yet.
So then I don't want to do the same thing. Yeah. Now this is better.
Yes, it is. It is fine now.
Wonderful. So primum non nocere. What does that mean? And that is why I was just thinking, this was a wonderful topic that WHO put patient safety from the start. So all our previous speakers have talked about, the very, the nitty gritties of what has to be done. I will talk about in a bigger perspective, a layman's language. That's why I said, let's go back to the basics. So the next 15 minutes or maybe even less time than that, what is patient safety? Very, very briefly, because I think our speakers have already covered it. And that is one thing I think most of us know. This is important. What we want to do. What we want to do means what actually every healthcare organization and every healthcare professional, when he gets up and goes to the organization in the morning, what he exactly wants to do. And then my slide gets jammed as usual. Yeah. And then what needs to be done. So there is a big gap between what we want to do and what needs to be done. And so that is what I will actually be trying to cover in the next 12, 13 minutes. Simple definition, layman's definition of patient safety. What is patient safety? Prevention of inadvertent harm. What does inadvertent mean? I don't think anybody, neither a doctor, neither a nurse, neither a pharmacist, when they get up, they have a bath, they say, oh, today I'm going to create, do 3 medication errors, or I'm going to take out the wrong kidney. But these things happen. Our speaker spoke about, how harm happens. Remember, Triona said it's been happening for so many years. So, but no one does it on purpose, but it happens. So what is the definition of patient safety? Absence of preventable harm. That is what patient safety means. That brings me to a simple question for my audience. You don't have to answer it, don't worry, not answer it loudly. Think in your mind and I'll get the vibes. Do hospital harm patients? Do hospitals harm patients? Everyone is looking at the other person and saying, my hospital doesn't harm, but his hospital harms. All of us actually are saying, yeah, it happens, but not in my hospital. So, do hospitals harm patients? Yes or no? The answer we all know. If somebody still says, someone is living in that denial, Sigmund's Freud state, denial mode or psychiatric mode, if anyone actually thinks they don't harm, refer to the IOM report 1999. It was just the tip of the iceberg. But I think it was a documented paper which actually told you the harm that happens. And this actually quantified that 98,000 people per year are actually harmed, inadvertent harm, that inadvertent harm that we were speaking. What does that mean? It doesn't make us bad. It just means that bad things happen in good hospitals. So let's talk, because we talked about WHO. I want to take you back to the concepts and the timeline of patient safety. Dr. Rana, can you guess when did patient safety begin? When actually did the first, unintentional or intentional thought of patient safety come? A lot of us, why lot of us? I think all of us, none of us were born at that time. That came in 1847 when Ignaz Semmelweis, he noticed, when I wash my hands, the rate of infection falls. What was that? Is that infection control? Yes. But what does infection control translate to? Patient safety. So this has been there from 1847. Then Florence Nightingale came. Everyone says she's the lady with the lamp. They know her for the Crimean War. But what did she actually do? She did some things which actually made the environment safer. People were living longer. Then we said, okay, then something came, JCI. Now, JCI came long time ago, but in India, JCI came in 2005. Again, talking about patient safety. Then came NABH. Then came QAI. In the meantime, Dr. Rana, there was one gentleman who came. He said, sold one book. He sold one book. No, absolutely nothing bad with the book. Every quality person worth his salt bought this book. Even I have it. But none of us ever opened it. But it talked about the checklist manifesto like they do in the flights. Okay. Then now WHO said, let us do something. Let us increase awareness for patient safety. This is hospital, this happens. Patient safety, there's a code. Yeah. All clear. Okay. So this also says patient is safe. Wonderful. So WHO patient safety happens. Then when we come to 2050, Dr. Rana, 2075 also we'll be talking about patient safety. Because from 1847 we are talking about it. We all know Rome was not built in a day, but it did not take ages, did it? But I am very confident that we will still be talking about patient safety, and that is why the next slide is why are we here? So briefly, I wanted to just sum it up. Patient safety is a neglected necessity. Why? Mostly spoken about. Everyone talks about it. Change is good, you go first. Generally taken for granted. Not always, but generally taken for granted. कि ये बाद में कर लेंगे, we'll do this later. Further, the other things are important. Always superseded by so-called business needs. EBITDA, top line, bottom line, cost cutting, staff cutting. That is more important. Someone spoke about training people, adequate staff, but then someone speaks of how to maintain your balance sheet and P&L. And the most important, it is seasonally practiced. You know what is seasonally practiced? The yo-yo effect. The yo-yo is that वो एक यंत्र है जो ऊपर नीचे आता रहता है. See, Dr. Rana is demonstrating it with his head. So, kabhi haan, kabhi na. So, here come the surveyors. So, 1 month before they come, we do everything. Here go the surveyors. Now, for 2.5 years, we don't need to do anything. Then they come again, then we do everything. So, what happens? Every healthcare organization wants to be a place where no harm ever happens to any patient. There is no doubt about this. I am telling you, everyone says we don't want to be an organization where harm happens, but remember, bad things happen in good hospitals. There are multiple accreditations nowadays from JCI to NABS to QAI. Everybody wants to be accredited, but there is one small rider. When the assessors come, when the auditors come, that's the time we will do everything. Rest of the time we'll just, fabricate, we'll make it up and we'll put it. That is a rider which is, they think, they are not, it's not for accreditation. It is for safety you need to do these things. Important question. I want you to look at this. It's one thing. What is the difference between needs and wants? So needs is something which is essential and wants is desires. I don't want to work. I want to be a millionaire. So wants is a desire, needs is something essential. Now, quickly, I want to ask my audience, think in your mind, when we talk safety and accreditation, is safety a need or a want? Is accreditation a need or a want? I can hear everyone saying safety is a need and accreditation is a want. You are absolutely correct. But when we actually get accredited, safety becomes the want and accreditation becomes the need. We need the accreditation for 10% more. We need the gold seal, but patient safety will come with it. So that is where one mistake happens. Always remember, if you're a safe organization, you can get accredited at any point of time without having to fear anyone or anything. But if you're an accredited organization, the same I cannot say because of the yo-yo effect, wo 5 din. So when you toss the coin also, you're saying, I hope I get head, but I hope I get tail also. And I hope I get the other thing also. So I want accreditation. I want my doctors to not complete their notes. I want my people to not wash their hands. And I want to be a safe organization. Dr. Anna, I hope you're agreeing with me. And, I can see the look on your face. But then they say, no, I'll take that later. Okay, one quick thing. What is the difference between healthcare and other industries? In hotels, hotels and airlines got a checklist that made travel safe. Hospitals adopted the principle mostly in spirit, not in practice, because checklists are all completed in the night. Hotels never advertise, please come to my place and eat and sleep here because I'm a clean place and I'm a hygienic place. Airlines never advertise that fly with me, I'm a safe, my accident rate is so and so. But every day on social media, I look at hospitals saying, I'm so proud and I'm so humbled that I have now been accredited and now I'm a safe place and I'm a safer than safe place. Shouldn't we normally be safe? That question comes to my mind. So I'm sounding like one big pessimistic person, but I'm not, So have things improved over the years? Yes. But what happens? Challenges, lip service. Many people talk about safety, but we don't invest in staff, in training, in systems. Look at the lines, the words which are in the different color. Blame culture still persists. punish individuals. Dr. Hassan also spoke about underreporting. It is not underreporting. Underreporting is if you don't know and you don't report. I'll call it fraud. People don't report here only. They know everything and they don't report. Fraud, falsification, dhokadhadi. Dr. Hassan, I will call it that. Because, when we say incident is something that is not normal but happens. And we have 30 incidents a month. 30 incidents will happen in one day only because, that is it. So underreporting is a challenge. Commercial pressures. We already spoke about it. So, my title of the presentation was only the top 3 things we need to do. One size does not fit all, but this is basics. If you know ABCD, you can become Shakespeare. You can write what you want. ABCD is important. Top leadership commitment. So, is our top leadership committed? Understand the systems approach. We all spoke about system versus individual. There's a difference between what we see and what it actually is. And the most important, there are no shortcuts. So when I say top leadership commitment, does leadership walk the talk? We give big talks, big bhashans we give about, how it is non-negotiable quality and all. But do we actually act on the ground? When consultants cut corners, do we act against them? Do we address the if not, then what? Top leadership, remember, they are the people everyone looks at. Systems approach. Healthcare is very complex. I am telling you till today, if one person says because of this person a patient died, you're making a mistake. No person in healthcare is so powerful. The Swiss cheese appearance tells us that there have to be multiple flaws at multiple levels, and then one day all those flaws will align. But still, we blame individuals. You nuisance fellow, you disgusting fellow, you didn't come for training, you're not here. Systems approach is never followed. Focus on systems. This is the last slide, but the most interesting and most important. There are no shortcuts. Sometimes we cut corners. In an emergency, it's okay. Never encourage violations or protocols in the organization. It is called cutting corners. Never encourage it. I always say we have to be non-punitive. I say, that's how we encourage reporting. But there is one time when I say I recommend punitive action for staff who will routinely cut corners. You know why? And now let us introspect. Cutting corners happens to you and we all do it. We don't do it in hospital. We do it at home. We do it at the workplace. We do it in the market. We do it everywhere. But in healthcare, when we cut corners, remember, it may cause harm to others. Someone else may lose a life or a limb. So, those were the top 3 things that I would like to have focused on. And with that, I think my 15 minutes are up and my slide presentation is up.
Thank you, Clive. Thank you. Well in time. I highly appreciate that, bringing time. But as well as quite, I would say, quite interesting. It's like a workshop. Learn while you do, So that type of presentation I always like. So thank you so much coming up and giving this talk to all of us. Thank you, Clive.
Thank you. Thank you,
Moving
QI.
on to
Thank you,
thanks.
Dr. Rana and QI for the opportunity, and thank you to everyone. And I just have one request from everyone. If you take back 1 point from every speaker and go to your organization, we will have made that change that we are asking the world to make for us. So
Fantastic. I think that's well said, Clive. I think that's learning at least 1 point from everyone. Thank you so much. Moving on to now, I'm moving on to the another actually, coast. Coast was a totally different area. Now going to Africa, and even in Africa, going to down south, South Africa, we have Jackie Stewart. She's going to talk about patient safety experiences in Africa and South Africa per se. Jackie is the Chief Executive Officer of COSASA. It's an accreditation body like QAI in India. So she runs this for last several years. And Jackie is a friend for long. We have been sitting on the SCOA Accreditation Council and the board for many years, and she drives the agenda of quality and safety in that region. So, not taking much time, the floor is all yours, Jackie. Thank you very much for joining. Over to you.
Thank you very much, BK. Yes, it's a bit like Triona. I'm going to say we're not going to mention how many years we've been friends. But we've worked together and it's always been a pleasure. And thank you for the opportunity to bring a bit of an African perspective rather than just South Africa.
And
Just checking.
congratulations for completing 30 years of Kawasasa.
Oh yeah, thank you. It's our anniversary this month. So we're very proud. Just checking, can you see my presentation?
Sir, but not in slideshow yet.
There we go.
Yeah, it's up. Nice, thank you.
Excellent. Just lose this. I'm just trying to lose the. There we go. Yeah, so thank you very much. And it's really good to follow Clive Fernandez because I can leave out half my talk. Because you covered a lot of what I said. We may disagree on some of the accreditation comments, but it's you've hit on a lot of the things I was going to talk about. So I'll skim over those. You said, BK, that I should talk about South Africa. We work across the continent, so I thought it'd be nice to pick out some of the things that are going on in the continent. Patient safety is a major challenge for us. A number of you work in countries and areas that are very under-resourced and struggling. We have the same issue where we have pockets of excellent practice. We have very good private sectors in some countries like South Africa and Kenya and Nigeria and Ghana have some very good private sector. But mostly our public sector is very, very under-resourced and under strain. In terms of national bodies, the WHO has done a huge amount of work, as Trina and others have spoken about, in terms of trying to encourage the implementation of quality improvement and patient safety strategies at a national level and then implement them locally. South Africa has a national patient safety reporting system. Kenya has just introduced the Quality Health Care and Patient Safety Bill, which is being debated very widely across the country. Happy to say they had some really excellent people involved in the development of the bill, but there is still debate about what should be, where the regulation comes in and where the improvement science should be. And Nigeria is working on a national approach for patient safety as well. So there's a lot of work going on. And I've just cited these three countries. In South Africa, the National Department introduced this national reporting system, which the ultimate reporting is to the Ombudsman if things go really, really badly wrong. But the challenge we have is people are not necessarily reporting because of all the reasons that have been alluded to in previous presentations, because the fear factor is still there. We do not have a national just culture. When things go wrong in the local hospitals, in the various provinces, we have a provincial structure where there is a Minister of Health at a provincial level and we have a National Minister of Health. But what happens when something goes wrong, the first comment out of the politician's mouth is heads must roll. So it's a lot of work still to be done to encourage people that our reporting system has to be a learning system. And as Dr. Fernandez was saying, very few people, I don't think anybody gets out of bed in the morning to go to work and cause harm to a patient. There are accidents, there are things that go wrong. So within these national structures, it'd be interesting to see how the system works in Kenya and how it's going to develop in Nigeria. But the fundamental is that we've got to get everyone into the belief that it is about a learning system. We've got challenges. I don't think we're unique in South Africa or other parts of Africa against the rest of the world, but staff shortages are a major problem. And we know there is a global shortage of medical and healthcare professionals across the globe, but our numbers are pretty stark. If they take the doctor-patient ratios, in Kenya it's 0.1 per 1,000 patients, in Nigeria 0.4 per 1,000 patients, and in South Africa 0.8 per 1,000 patients. And it's the challenge we have as well is that these numbers are not universally universally applied across the country. They're in pockets. So we have a big problem in our rural areas where often there is one doctor per 100,000. I mean, it's really critical. We have a split between public and private sector, where the private sector is often well-resourced and has a good number of specialists, and the specialists are not available in the public sector. Happily, in South Africa, we're starting to see a lot more public-private partnerships and the opportunity of carrying out work in the private sector on behalf of the public sector. And I have to say that COVID did a lot to help us in that, in terms of bridging the public and private sector gap. Not universally, but it's definitely helped and definitely improved it. Our nursing ratios, nurse-patient ratios are equally bad. They're showing in Kenya, I didn't have figures for Nigeria, but in Kenya it's about 1.2 per thousand patients. In South Africa, about 4.2 per thousand. Again, this is an average across the country, but the situation in rural areas is much worse than it is in the urban areas. It usually means that a nurse is looking after somewhere between 30 and 40 patients per shift, which is really difficult to manage in terms of being aware of everything that is going on. And often there is only one qualified registered nurse per shift, and the other staff are nursing auxiliaries or students or nurse aides. So that is also a big problem. Other challenges include, obviously, staff training. We've had a big problem with our nurse training in South Africa. We had colleges closed a number of years ago. The curriculum was changed and then wasn't implemented across the board. We also have a challenge, and I'm not sure if it's the same in other countries, where when people are joining the profession because it's a job. They're not joining because they really want to be a nurse. So when I qualified, it was a vocation. You were called to do it. You really, really wanted to do it. And as we're looking now, where we're seeing the millennials coming into training, they want answers. They want answers now. They're not necessarily prepared to put in the softer side of care, if you like, the compassion side of care. And also we're finding people are cut, and Dr. Fernandez talked about it, there are no shortcuts, but we're finding people are cutting corners. They're not recording the data. If we don't have data, we can't measure. If we can't measure, we don't know what's going on. We also have a problem with poor governance, and this is across the board. It's and it goes right the way up. We have a lack of good quality people to take up the governance roles, and we have people who are put into governance roles who don't necessarily have the background. So our governance is a major issue, and I think I can say that across, well, certainly across these three countries, it's the same, but in many parts of Africa, we see exactly the same. We will see, for example, a doctor put in charge of a hospital who's a very, very excellent clinician, but he's never been trained in management. He's not been equipped with the skills that he or she needs to necessarily do that. Our board structures might be weak, so the governance is just generally not as good as it should be. Added to that, we have a lack of leadership. Leadership at all levels of an organization. And again, it's often that we're putting people into posts who are not necessarily qualified for the posts they've been put into, or they don't have the required experience for where they're going. And it's also about not being visible. And for me, that's one of the most important things, is that leadership should be visible in any healthcare facility. Excuse me. Sorry about that. As with any emerging market or developing country, the resource constraints are quite phenomenal. We have, let's say, the lack of human resources, but the lack of financial resources. The withdrawal of USAID has had a major impact in Africa, where patients have suddenly not on programs, staff have lost their jobs. But in some ways that's been good for us. It's a wake-up call that you cannot rely on a third party to fund your healthcare system and expect it to function well. So it has caused a major problem, but I think it is a wake-up call that hopefully we're all paying attention to and looking at how we resource our health systems properly, and how we reduce wastage. We have a massive problem with wastage, and we have a massive problem with corruption, which means that the resources that are there to keep patients safe and deliver quality care are not necessarily there because they've been siphoned off to people who think it's their right to have that money. We also have a lack of research. I'm happy to say this is getting better. There is more African-based research happening, and I think that is really good, but we need more. And more research into what really constitutes good quality care and the evidence that we can show the accountants and the financiers. This is really what we need to ensure patient safety and ensure patient care and good quality care. The environmental factors are huge. We have a lot of, in many countries, we have old mission hospitals that were built years and years ago, very old, dilapidated plant, which means that it's more difficult to maintain. But in our accreditation program, we find the lack of preventative maintenance is one of the biggest factors. And if you don't have preventative maintenance, you have water leaking through the ceilings, you have just the general fabric of the building is getting poor. So then you have uneven floors that can lead to patients falling. The oxygen systems, the power systems are not maintained well, and we have hospitals that are without power for long periods of time, which is massively dangerous to our patients. And then we find, in terms of the maintenance, for example, if you know your power is going to be going out, you need to make sure your generator works. And we find that hospitals don't test the generator, so when it does need to kick in, it's not working properly, or they can't afford the diesel to keep the generator running for long periods of time. So real challenges that, and of course, if your power goes off, the incubators go off, our babies die. So real challenges from that. And also an issue of equipment, where we have equipment, there's a lot of equipment donated, which doesn't necessarily meet the local requirements. And then our second challenge with equipment is the lack of servicing providers. So for example, people may opt to buy equipment from China because it's more cost effective, they think. But then when they ask to get their local engineers trained so that they can maintain the equipment, they're told by the provider that, no, we will send the engineers, we don't train other people to maintain our equipment. So that's a big challenge. And during our visit to hospitals, we often find roomfuls of equipment that cannot be, or has not been serviced, cannot be serviced, is not functioning. And the waste is phenomenal. And if the equipment's not there, people can't treat the patients in the way that they would want to do. So those are real issues for us. I thought it would be worth just talking about the categories of reported incidents, where incidents are reported, and not every hospital, not every country has a reporting system. They're definitely getting better. We know that in the Western world, in the developed world, falls are probably one of the major incidents behind medical errors, which we know they're now number 3 cause of death in many of the developed world. But we found when we were running an incident reporting system for a large number of facilities, and even today, with this been like for the past 10 years, clinical management is the biggest biggest number of incidents is clinical management. We then have behavioral issues and performance issues. Often these poor performance often relates to a lack of training. But behavioral issues in terms of bad behavior, people working outside of scope, people being negligent, and that's a major problem, because obviously we're not going to punish you if you make a mistake. We want to learn from that. But if you're negligent, then the punitive action needs to be taken. Then it's organizational management. And that's been a major problem because it also relates to procurement and stock. And when we started the program across a number of public sector hospitals, people were saying, "Oh, the doctors won't report. They don't report these things. They're not interested." And the doctors did report. And we questioned, saying, "What made you report?" And they said, "Because something happens. When we reported before the system was operating, nothing happened. Now we report to you and something happens," because we had a system that would, as soon as an incident was reported, if it was SAC 1 or 2, severity 1 or 2, it would immediately be emailed to the named people in the hospital. So that would include the hospital CEO, the head of risk, and to the provincial structures as well. And when they saw this happening, they responded. So that was a very important factor, that if you have a reporting system, you've got to make sure that people respond to what is reported. Then it comes medication, IV fluids, and documentation, and falls is about midway down the list. Medical equipment, pressure ulcers, and then accidents, occupational health and safety, blood product related, the building structure. And interestingly, hospital-acquired infection comes quite low down the list. I'm not saying our hospital-acquired infection rates are low, just saying they're not necessarily reported. I mean, there's a debate to be had as to whether people are not reporting because, oh, that's just what happens, or nothing's going to change because we don't have the right IV, we don't have the right antibiotic regime. Difficult to understand exactly why that is the case. But I say for us, it's very interesting that clinical management is top. And that, again, related to the shortages of staff. It related to doctors working long hours and being very tired, sleeping, and then not waking when they were called to go for an emergency. Also, people working outside their scope. That has been a major problem. We had an incident, for example, where an anaesthetist was told to anesthetize for a dental patient. They said, "I've never done that before," newly qualified. Said, "I've never done that before. I don't think I can do it." No, you must do it. And the patient died, and now the anaesthetist was being blamed. So very, very heart-rending incidents happening. And I think that's something we just have to make sure that we have the supervision for our newly qualified staff, that they know what to do. And I always say to staff, if you're newly qualified, never, ever be afraid to challenge someone who is senior to you. Never be afraid to say, "I don't know. I've never done this. I don't know, and I need help." Because if you don't, it's likely that people will just let you get on with it, and you run the risk of being what they call the second victim, because the damage that we do to healthcare professionals who make a mistake and who are not well looked after afterwards is huge, and they leave the profession, or they continue, but they practice very defensively. So it's really up to all of us to make sure we look after the staff, but we do make sure that we learn, and we do make sure that we take them through the processes and counsel them about what happened and why it happened and what could be done differently. And now it's come into a case study. This was carried out by the team at Avenue Hospitals in Kenya. And it was just when they started in the accreditation program. So they were very aware of quality. They were really looking to improve the quality of their services. And it was back in 2020 when they entered the program. They noticed a worrying increase in patient falls. This is after I've said that falls is not necessarily at the top of the reported incidents. But in this case, They went up from 2.69 per thousand patient days to 11.1 in a period of 3 months. So what they realized was as they investigated was the cost, including litigation and managing the client injury, because most of these were patients over 60. They had quite serious injuries from their falls. And I've put this into US dollars. But the cost of that was estimated to be nearly 200,000 US dollars. And about 78% of that was in legal costs. Only 22% was actually the cost of managing the client injury. They put in place a fall reduction quality improvement project where they started to looking at exactly what were the problems. They found one of the big problems was that staff didn't know how to recognize the risks related to falls. And I have a personal example of this. I wasn't in this particular hospital, but I was admitted. I had broken a bone in my foot, and I was admitted I was in a wheelchair. I had a pair of crutches. I had an orthopedic boot, and I was assessed, and all the paperwork was done. And when the nurse went away, I looked at the paperwork and thought I was assessed as a low risk for falls. So when I called her back, I said, I think you might see there's a few clues: the wheelchair, the crutches, the orthopedic boot, the fact I have a broken foot. Maybe you want to revise this assessment. They also did an environmental audits because they found that there were uneven floors, there were problems, just environmental problems. So they did the environmental audits, and they issued clear guidelines about what should happen if you find an environmental problem. They started to manage the risks from falls and to monitor the activities to prevent falls. So having trained the staff, now they were monitoring this. They had real data to see whether there was improvement. They needed to spend money, and that went into putting down new floors, buying new beds, recruiting new nurses because they had massive staff shortages, and spending money on training. And that was about just 155,000 US dollars. But what they found, having done that over the next 2 years, they were doing a very careful monitoring. The cost of litigation dropped to just over 6,000 US dollars. It was a 96% reduction in the litigation cost, which is a massive saving. But interestingly, what they saw over the period of time, and interestingly, as they were coming to the end of this study, it was when they achieved their accreditation. So it was a great moment for them. But their net promoter scores had gone up in 3 years from 45 to 85. So that's about what people say about you. And their revenue growth went up by 20% in the 3 years. So I think it's just an interesting case study to finish on, to just show that if you have the data, if you know what you're doing, if you've measured it, and you're using the data, you're using the measurement, you can improve patient safety dramatically. And making sure that everybody knows it's their business. Because I always say to people, look after, and Dr. Gupta, I think, said it, your family is the most precious thing to you, but treat every patient as if they were your family. Thank you. I'm going to leave it there. BK, I think I'm happy to take questions, but I'm also conscious of time. So thank you.
Thanks, Jackie. Thank you very much for bringing the continent to us. The great job being done in that part of the world is really remarkable. Thank you so much for sharing all those things, how these smaller countries are developing their own national quality and patient safety strategies and policies to drive the agenda. So thank you so much, Jackie, for that. Before we move quickly, Chandni, may I request you please click a picture? May I request everyone to please switch on your video camera so Chandni can click a picture, and then we resume for the next talk. Thank you, everyone. Yes.
Done. Thank you so much, everyone.
You did? Are you sure that you have taken the shots? Everyone captured?
Yes.
Great. So thank you everyone. Now moving on to the next talk by Dr. Parvez Ahmed on role of design in patient safety. He is currently the director of Chandan Group of Hospitals in Lucknow and also the chair of our technical committee at QAI. He is into quality safety designing. He is designing hospitals which meets the requirement of any standard per se. So thank you, Parvez, for joining. Over to you. Thank you.
Thank you so much. Very good evening to all of you. I am audible and visible my slides.
Yes, both. Thank you.
Thank you, Dr. B.K. Rana, and thank you, QI, for giving me this opportunity. And I'm going to present role of design in patient safety. I have restricted myself to complete my presentation within 15 minutes, although there is
Thank
so
you.
much to say and talk about, but I will speak only few points, few relevant important points. There is a very famous saying by the statesman and the former Prime Minister of United Kingdom, Mr. Winston Churchill, who said that we shape our buildings and thereafter they shape us. So very important statement given by him during his prime ministership. Well-designed hospital cannot only prevent harm and injury, but also provide psychological support, restore resources, and aid the healing process, including providing safe and secure environment in the hospital. Basically, there are 4 factors who are affecting the safety. Number 1 is that safety and infection control practices adopted and practiced by the staff working in the hospital. Number 2, trained manpower in terms of doctors, paramedics, and other support staff who practice to maintain the safe and secure environment in the hospital. Third thing is instrument, equipment, and PPE. So that's depend on the caliber of the individual hospital, that how latest technology they are using in their department or in their hospital. And the 4th important thing is building design, which is very, very important. Reason behind it that because you can replace the new equipment or new technology, you can bring the new manpower, and you can provide the training and on safety and infection practice guidelines to the your staff. But it is very difficult to change the do the modifications or change the civil infrastructure. That's why the building plays an important role in the safety. These are the few related statutory as well as safety related requirements. I'm not going to go in deep in these guidelines. Number 1, that every country must be having their building code and structure. So they have to follow their national code guidelines to maintain electrical safety, chemical safety, fire safety, facility safety in terms of gas manifold area, liquid oxygen plant supposed to be in the open area, diesel storage area, maintaining the water tanks with adequate storage, etc. As per the norms, at least 455 liters per bed per day consumption is required in the hospital setting. Radiation safety in terms of their proper layout approval from the competent authority, maintaining the thickness of wall, providing the lead glasses and lead shield, and pollution control and waste disposal also plays an important role in designing the hospital settings. These are the some planning and designing of building. Number 1, that we have to follow the zoning concept in all the buildings, and we have to maintain the patient flow in terms of their emergency, diagnostic, or OPD services. Faulty building design and poor ventilation and poor light lead to the sick building syndrome. Sick building syndrome, we call that, whereas this building is poorly designed, there is a poor ventilation, poor light, and mismatch of the zoning. Hospital zoning comprises of outer zone, that's include emergency, OPD, reception, registration, admission, and administration. Intermediate zones include diagnostic pharmacy, nucleus zone OT, ICU, labor room, and inner zone contains of indoor patient as well as wards. So as you must be going in the hospitals and visiting that, so all hospitals are divided into the 4 zones. But it's important that how hospital planner and designer, they set up this hospital zoning inside the hospital. These are the few safety aspects. So hospitals should be good ventilated and provision of sunlight should be given. And we have to identify circulation areas, especially for staff, doctors, patients, and material. So individually, they can have a movement to maintain the proper circulation. The floor of the hospital should be designed in that way that are free from the obstructions and slip resistant and uneven. The staircase, ramps, and lifts should be provided with substantial handrails and other suitable supports means to prevent slipping whenever necessary. The healthcare standards of the staircase is that the riser bin supposed to be 10 to 15 centimeter, not more than that, and trade supposed to be 30 centimeter. The ratio of the ramp should be 1:10, which is the healthy, although we can minimize up to 1:8. Lift should be able to accommodate the bed inside the lift. And adequate fencing should be done on terrace or in patient care areas to prevent fall. Critical care areas such as operation theater, ICU should be separated from the general traffic. So there's supposed to be no mixing of the human traffic. All patient toilets should have accessibility of wheelchairs with hand grab bars along with provision of call bell system to call the nurse in case of an emergency situation. Seamless finish flooring, false ceilings, walls should be given, and clear height of ceiling supposed to be at up to 3 meters. Although in certain areas it can be up to 2.4 meters. There should be proper alarming system to maintain the safe and secure environment in the hospital related to fire, public address system, to maintaining the different codes, oxygen failure, and nurse call bell, etc. Centralized or decentralized nursing station should be provided with scrub with availability of clean and dirty utility. Bed to bed proper distance and visibility of all beds from the nursing station should be provided. Provision of wash basin, elbow operated at all nursing stations and provision of hand scrub at the entrance of critical care units. So it's a very, very basics and important tool. In fact, the WHO guidelines there that to maintain the hospital acquired infection rate, we should have a proper wash basin and hand washing techniques in the hospital. There is supposed to be provision of washroom for differently able person in the healthcare setting. Breastfeeding room supposed to be provided if we are having a pediatrics and obstetrics gynae in the scope, and there is supposed to be proper play area for the children. These are the some safety aspects related to infection prevention and control. Proper space for temporary biomedical waste storage area supposed to be there as per the local biomedical waste management guideline. There's supposed to be proper isolation room in ICUs as well as in the ward with the negative pressure. Ante-room with air curtains can be installed at entry of patient care areas such as ICUs, operation theater, sterile area as well as in the delivery suites. And proper utility room should be provided in terms of clean or dirty utility, or there might be provision of centralized loose room. Let's coming to the radiology and imaging services. It's very important area, and we have to follow our local radiation guidelines. And wherever we are using the radiation generating equipment like CT, X-ray, mammography, cath lab, radiation bunker, etc. Layout approval should be obtained from the concerned local bodies, and thickness supposed to be maintained as per the radiation guidelines, and proper radioisotope store area supposed to be maintained as per the local guidelines, and nuclear medicine waste supposed to be disposed as per the guidelines to maintain the safe and secure environment. Lab services. So separation of services supposed to be provided in the laboratory services. That's include your biochemistry, hematology, microbiology, histopathology, etc. Area for storing of hazardous materials like reagents should be supposed to be provided. Working counters with lab sinks for the lab technicians and healthcare workers who are working inside the lab and proper eye wash and shower provision to be given in case of spillage in the laboratory service. There's supposed to be provision of dirty utility and autoclave room for disinfecting. Coming to the zoning, because hospitals is having a few departments who plays a very important role, and at most provision of zoning supposed to be maintained to maintaining the zoning concept as well as for maintaining the safe and secure environment. Number one, so these 4 departments which follow the proper zoning concept and very important from the accreditation point of view also. So operating room, as we know that we are having a 4 zone, protective zone, clean zone, sterile zone and disposal zone. So operation theater is supposed to be built in that sequence. Central sterile supply department should have a proper receiving area, washing area, cleaning area, packing area, sterilization area, sterile store area and issue area. Same way in the kitchen and laundry supposed to be have a proper zoning. Patient room supposed to be provided with proper ventilation. It might be mixed ventilation, natural ventilation or mechanical ventilation. Provision of natural light supposed to be given inside the patient room. Flooring, curtains and upholstery could have antibacterial properties and flooring should be anti-slippery. Provision of nurse cal bell supposed to be there inside the patient room. Handrail leads from the patient bed to the bathroom. Bathroom doors opening outwards with accessibility of wheelchairs and availability of hand grab bars and call bells supposed to be there inside the patient room. ICUs should have a controlled access in critical care areas to prevent any unauthorized entry inside the ICUs. There's supposed to be double door system with anteroom to maintain the infections. There's supposed to be viewing windows at appropriate areas. Noise control and sound insulation provision supposed to be there. Centralized nursing station with clean and dirty utility equipment or storeroom. Provision of isolation room supposed to be there inside the ICU with proper negative pressure, and breastfeeding room in nurseries and separate area for septic nursery and non-septic nursery supposed to be given. These are the few examples of isolation room. Although during the COVID pandemic, we have learned a lot about the infection control and isolation room. So that's the design of the isolation room. There's supposed to be double door system with anteroom. In anteroom, there's supposed to be provision of hand wash basin, and some gown change and PPE. And there's no supposed to be recirculation of air. And all isolation rooms should have a negative air pressure and there's supposed to be at least 6 to 12 air changes per hour if provision of mechanical ventilation is there. Studies has proven that copper is used for alloy surfaces. It's play a very crucial role to reduce infection load in the healthcare setting. So these kind of fixtures can be now efficiently used in the hospital setting. Legal signages as well as directional signages also play an important role for providing the safe and secure environment. So all kind of, it may be fire signages, no smoking, biohazard signages, electrical signages supposed to be displayed on the appropriate location. Use of information technology, because now these days, information technology is playing a very important role in maintaining the safe and secure environment. So especially that providing that intercom facility, public address system in the hospital setting, nurse call bell system, and use of radio frequency identification bands. And now these days, AI is also emerging very fast as a information technology. So thank you so much for your patience and all. Thank you.
Thank you, Parvez. I think that's just totally different thing, but the most important as regards to safety, whether it's a patient safety, staff safety, or anyone coming to a facility is important. And then some areas which are critical in a hospital like ICUs or operation theaters and other things that need to be really considered for safety. So thank you so much for sharing your ideas on design safety. Moving on to the next role of patient for patient safety by the foundation, by chair, Mr. Somital, who is chairing Patient for Patient Safety Foundation. He is the former chairman of NASSCOM, very actively involved for a few years. I known him for last few years since we set up this foundation. So, but a lot of things have been done. Kudos, and not taking much time, I would like to invite Mr. Som for your deliberation. Floor is all yours, sir. Thank you.
Thank you, Dr. Rana, and appreciate your inviting me. Varsha, can you just put on the slides, please? Dr. Rana, we have been hearing about patient safety, and I am not a doctor, I'm a patient. And as it often happens, while we talk about the patient, somehow patients come last, right? And I think we have to change that and put patients in front, because all the hard work that you're doing is for us. And I think what I'm going to share with you is how we as patients can help the healthcare providers in reducing harm. And that's what I'm going to be talking about. This foundation was set up 3 years back. Our vision is basically to get patients and caregivers actively engaged and working with the healthcare providers to ensure that we can prevent harms. And I'm just going to take you through some of these slides here. We are a trust, not-for-profit. Everything that we do is freely available to all patients, caregivers, and of course also to healthcare providers whom we work very closely with. Next, please. So, since this year children health is the one that is the topic, I'm just going to very briefly mention and move it. We must remind ourselves that children are patients with a difference, and the difference is that they cannot express what the adults can, and they have to express it through their caregivers, through their parents, and hence I think need a very different way of addressing them. Also, I think while we have pediatricians, and I think they've been doing an amazing job over the years, the things are changing very rapidly. While they have the common problems that children have, but I think the new things like obesity, mental health, screen time, malnutrition, largely because of the easy availability of food on order. The urban environment has infection, allergies, and of course, due to lack of supervision, accidents are also increasing. So there is a very different need for children at this point of time, which we must all be conscious of. They are, but I think we must highlight this as we talk about patient safety this year. Next, please. Because of this, the challenges of parenting are also changing, right? The structure of the families has changed. Families, both parents work and they have to balance their life along with children. They have stress. Digital challenges are both for children as well as for the parents. And sleeping habits, socializing is as much true for children as with parents. So I think the modern parenting is struggling to do this balance. And I think this also adds to the issues. Next, please. And that would mean that the changing role of pediatrician, if we look at it, it changes as we move during the years. I think we have done this. But I think the current issues on emotional growth and social consciousness is creating new kinds of problems that I spoke about. And hence, the empathy that's required by a pediatrician is quite different and has to be managed, because half of it is about empathy. Next, please. So, and this is to our parents, and that's what we keep doing. We don't talk to just the healthcare providers because you're doing all that you can, but here is our counseling to the parents of what they should do, not ignore. If you remember in the good old days, if the child was not speaking, the mother or grandmother would say, no, some children speak late, they walk late, but then you later on realize that it was autism. So I think there are many things here that I think parents must know that their role is changing. It's not about just providing them great food, great schooling, and so on, but they have to keep a very different eye on the health of their children. So I think this is basically what I think we're going to push this year, and not only now, but years later as well, because children, I think, are the base of our society. And I think we need to ensure that if they are healthy now, they will remain healthy later as well. Next, please. So as we go here, we all know this data as to how much harm is happening, right? And this is in spite of phenomenal amount of effort that's being put in. This is in spite of all the accreditation and the processes that are put in by QAI and many other accrediting agencies. There is harm happening. Also, if you look at it, the burden of harm is increasing. Diabetes, hypertension, it's not such a great crown to wear that we are the disease capital of the world, but the fact that every fifth citizen is an Indian, obviously we will have by numbers, very large number of people, and we have an issue on our healthcare system being already burdened. So we collectively have to work towards not only avoiding harm, but also ensuring that the burden on the healthcare is reduced by taking preventive actions. Next, please. So, we know what's happening, right? So we're not talking about blame. The errors do happen. We know what kind of errors happen because in the hospital situation, but errors are happening by the next two circles that you see, which is patients, omissions by patients, ignoring symptoms, late presentation, not giving complete information to the doctor. And then when they go back home, they again have issues where, they don't follow through the treatment plans that have been given. They don't comply with the protocols that have been defined. So I think we need to not only focus on the left-hand side, but on the right-hand side as well. Because if patients are aware and engaged, a lot of people say, nay, these people will read Google Baba and come back and all that. No, I think if they're aware, they will take off your burden. Yes, some of them will ask questions, but an aware patient will actually prevent harm and help you in that. Next slide, please. So how will they reduce harm? We can better know about symptoms, not avoid them, provide complete information, always keep the medical records updated, because when you meet a doctor and people keep shifting from one hospital to the other, doctor to the other, one doesn't know the other person. So your records must be there. You must ask to clarify your doubts. And we have seen how many prescriptions which are handwritten are misunderstood, wrong medications are given. We never ask for a second opinion. We think the doctor will get upset if we take another opinion. And we have had disastrous issues. Mind you, we must not forget that we may be going to a hospital, but eventually it's not the hospital treating you, it is that one single doctor who's treating you. And if he or she in his judgment or her judgment is wrong, then it's not the hospital, it is this doctor, it's a judgment. So I'd rather have another judgment from somewhere else. So these are various ways that we can, as patients, get involved and prevent harm. Next, please. So what we do is actually prepare patients in a very simple language, which is patient-centric, no jargon, tell them about early detection, risks, consequences, awareness. You're not going to be Googling out if somebody in the house is having a stroke. Do you know what the symptoms of the stroke are? Do you know how to manage an emergency? So we provide them actionable tips, right? We tell them about their role and responsibilities in the hospital, both for caregivers and patients. And of course, our biggest collaborator here is the healthcare providers, which means all of you, right, for helping us engage with them. In fact, we are so overwhelmed with the response we've got from healthcare providers who are taking our material and have now started sharing it with patients. Next, please. So this is some of the material that we have, and this we just took out some which are related to children. Correct sitting procedure. Taking care of your eyes. Dog bites. How can you prevent, and what do you do if you have one? Right. These are all issues that children face, and I think both at home we can be aware of them, and also in many of these when they go to, for example, an eye clinic, some of these posters can be used. Next, please. And similarly, for the family, preparing before visiting a doctor, the doctor on an average sees 40 patients in a day in OPD. They do not have time. If we are not prepared to use that time properly, we will have a wrong diagnosis. It's the simple stuff that we do. Tips for medication safety, which represents 50% of all errors. And of course, some things like what is the first aid kit that you should have at home for both your kids and your family. So these are just samples of it. There are many more. Next, please. So how do we do this? So we prepare this content, every content we research for the Indian context. We only focus on harm. We are not into well-being. We are not telling you how to eat well, get up early, go for an exercise. All that is not there. There's just overload of all that gyan. We are only giving gyan, if at all you can call it, on how to protect yourself of a potential harm. It's one life, you can play a role. So we are going through with this content, which is approved by, we have a panel of doctors, we have experts who look at it, and that material then goes direct through our website, conferences, social media, through partnerships with corporates, and through, of course, the healthcare ecosystem where hospital labs, through QAI, NABH, and others, and of course, the associations that are there. And mind you, the focus is not only on patients, we have to focus on not yet patients. What's the point of telling somebody who's already a patient of how they should be precautionary? We have to prevent it before they land up in a hospital. Because if they land up in the hospital, the harm, half of it is already done, we can prevent it. So this is the way we reach out. Next, please. Over this last, Varsha, can you move this? So I think we are just removing the gap between the patient and the provider. As you know, there's a lot of mistrust, but if we can educate them, that mistrust goes down. For the healthcare providers, we had suggested patient advisory councils, which are we are very energized that they are getting set up now. We have a large health library, but library is for people to seek information. We believe that seeking is very difficult for patients, so we push the information to them through WhatsApp, through seminars, so that they read it, not because of choice, but because there is no choice when it gets to harm. And similarly, with the patient community, we do the same. Next, please. So in just the last 2 years that we've been working, we have built in more than 900 educational resources, articles, posters, videos, 20,000 plus families through workshops, 14 lakh families or households every week get on one topic some information from us. 53,000 plus healthcare professionals directly, indirectly are engaged with us, 1,100 hospitals. We have done in this period 50 webinars. But while I'm throwing all these numbers, we have 1.4 million people, and that could translate to almost 350 million households, right? It's just the beginning. It's a huge task, and we hope that everybody will work together and ensure that we don't treat patient as a patient, but somebody who is the center of everything that we are doing, and educate and make them aware so that we can prevent. Next, please. So there are many things that providers can do to improve communication, because if we can improve communication while we will do our work, it will be helpful. We know that you have less time, but there are various ways. We have provided all these tools. We know that you can't do it, but we will provide you the tools. Use our material. It's all free. Download it, put it up. And we are very encouraged that many hospitals in their OPD, IPD, in the rooms, in the pharmacy, are putting up the posters that we have provided to them. And, we can help you with this. I'm in the 70s, and believe me, been through many hospitals and surgeries. I always have signed the consent form without ever anybody telling me the content of the consent form. It's a fact. It's a requirement by QAI and NABH, but then it becomes a documentary evidence. In real, it doesn't happen. We know why it doesn't happen. You don't have the time. But we will help you. Instead of your doing the consent form and teaching them, we will provide you videos, we'll provide you content, which you can ask the patient to actually, through a QR code, access it and be able to do exactly what is written in the consent form. So you do not only in the letter, but also in the spirit of the consent form. Next. So we have many partners. I hope this slide, we have many slides that will need to fit in all the logos that we have here. This is just the beginning, but we do hope that more and more people will join us in this journey. As I mentioned, it is for people of any age. Young people are having diabetes and heart issues. They have to take care of their parents. Senior parents are falling. I think all of us can actually prevent the need for hospitalization, reduce the burden. We are never going to have enough hospitals and enough doctors. We have to reduce this. There is no choice. Next, please. So can you move the slide, please? So we basically have all our stuff available on our website. We have QR codes that are available. You can actually download things for yourself. And here we are now doing it in regional labs. I know we have just about 38 people attending this, but if you can partner with us, help us. The job is very large, but we are committed. We think how big the task is, we have to get it done. So that's my brief presentation. Thank you very much.
Thank you, Somsa. Thank you very much. As lively as it is, fantastic to bring us all information about the foundation and the great work you and your team is doing. It's really touching that we could touch so many people and organization in very short period of time. So congratulations and well done, sir. Thank you so much.
Thank you.
Moving on to the last one, the great expert, Dr. Peter Lackman, a great scientist, I would say, in medicine, author, a researcher, and an expert for quality improvement. And he was the CEO of International Society for Quality in Healthcare, ISQA, for a couple of years. And I had the opportunity to work with him on the board of directors of ISQA at that time. And I remember how he would drive the board and board members and keeping them at task. So it's really an honor to listen to Peter as always. So thank you very much, Peter, for joining from US. I know it's early morning, but thanks very, very much for your commitment to join this webinar. Floor is all yours, Peter. Thank you.
Okay, can you hear me now, BK? Well, good.
Thank you.
Thank you for inviting me and for being on the talk. I've listened to a few of the speakers. I was also supposed to be on the ASQA talk earlier this morning, but that was 3 a.m. and I said I'm not waking up at 3 a.m. for my talk there. So they had a recorded version. It's a similar talk I'm going to give, but let me share my screen and then you'll see I'll be building on a lot of things. Yeah, I'll be building on a lot of things that the people have said earlier. Basically, this is a call to action. This year, I was fortunate to be asked by the WHO to co-author or to coordinate the World Patient Safety Goals with them. So I'm going to give you a bit of the story about the World Patient Safety Goals, which is a call for action. So now that you've heard the presentations from everyone, we have come to the time to commit to action. That is where we are right now. And I'm going to show you the goals. And as you go through the goals, I want you to choose one goal that you're going to commit to. And that's the important thing. There are 5 goals, and we're going to commit to one goal. And within each goal, you can commit to one thing, at least, that you're going to do tomorrow. There are lots of things in each goal. And you can, and that's the time. It's the time to commit. And I'm going to ask the speakers, the speakers and the audience to write in the chat at the end your commitment. I commit to do this tomorrow. Because that's the time of the talks now. It's good we heard all the good things. I heard Jackie and I heard the last 5 talks, so I'm not going to go through them. Okay. So I'm going to take you back to 1989. Is that the UN Convention on the Rights of the Child? which people often forget nowadays. It's not a popular thing that people talk about, but this is what all the countries, bar two, one is the United States, and the other Somalia, have signed. The new countries may probably haven't, but that every child has a right to the best possible care, etc., etc. Now, to do this, you can see at the bottom, rich countries must help poorer countries. And you can see we're in an age when rich countries are stepping away from helping poorer countries to achieve this aim. So poorer countries must help each other, and that's very important. Now, you heard this in the last talk, that the children have problems. Firstly, developmental. They go through different stages. So a neonate is very different from a young infant, very different from a young child, very different from an older child, very different from an adolescent. They rely on others to care and support and speak up for them. And because they all go through different ages, they have different epidemiologies, and more importantly, they also suffer from different impacts of social determinants of health, particularly poverty and war. And this is happening. You can see this today in Sudan, in Gaza, in many parts of the world. The people who are most affected are the children in the war, and the poverty, the people most affected are the children. So we have a duty to really pay attention to children, and that's why this year is our focus on children and newborns. And just looking at deterioration, because this is one of the big areas, is we call it this a slippery slope. I've taken this from Australia, and this shows you what happens to a child, or an adult actually as well, if they have deterioration. They go down the slippery slope. The difference between a child and an adult is that the child can't say they're deteriorating. They rely on the parent. And also, a child compensates very well and then just falls off the cliff. So they go longer and then they suddenly just fall off, whereas the adults, you can pick it up earlier. So the slippery slope is really what we want to really stop happening. Now, the background for this year is on previous WHO work. And here you can see WHO programs that happened before. Diagnosis was last year, patients the year before, infection control before that, medication safety before that. These were all previous campaigns that we've had in WHO. And so everything in the goals is based on WHO goal documentation. So when we were doing when we had the team that I assembled, who came from India, Kenya, Canada, and myself from Europe. So we had trying to get us from most WHO regions and from Japan. When we put these goals together, we had to go back to all WHO documentation to ensure we weren't giving anything that's not in document, not recommended WHO already. So you won't see anything strange in these goals. So this is the document, the World Patient Safety Goals. You can download this at WHO. If not, I can put it in the chat afterwards so that you can get to do it. And I'm using some of the Blerta, who's the lead of WHO flagship now, is using some of the summary slides that she has used on her talks as well. I've just rebranded them a little bit for my talks. The theoretical background is based on what is going to be published later this year. It's not published yet. The WHO is going to publish a human factors document. So when we did it, I said that we need to look at it in terms of what WHO is going to publish soon, which is the human factors, which is based on this one. So I'm showing you this one, the SEEPS model, which is a human factors approach. So we wanted to incorporate human factors into the goals so that people would be able to relate it to the next document that's going to come out, hopefully at the end of this year. It's currently post reviews. So it's the document on human factors in healthcare. And it's based on understanding how the work system, you heard earlier how the work system was so important, on the processes people do, how they get their work done, and how they measure what they have done, and how they measure what happened with the patients, the professionals, organization, and how they may get desirable or undesirable results. And this is really what we're really trying to do. So when you look at the goals, you'll see we follow this process quite closely. So let's look at the goals. Earlier on, it was said patients are not always the first. So Helen Haskell, who worked with me, I forgot to mention her, she was the USA version. So Helen, who heads World Patient Safety Alliance, and I worked on these goals with me. And you can see the way I've done them is that they're all in a kind of interlinked. There's no one after the other. It's not a linear relationship. They're all interlinked. So the first goal here is engage children parents. So I'll go through these. So as people, for example, you have to train the healthcare workers. You have to promote healthcare awareness. I'm not going to read these all because you can all get them in slides. So the people will have tasks to do. Okay. And this is, you can heard already what has to happen. Include family views and care process, involve parents in decisions, share decision making. To do that, they'll have tools. The WHO has got many tools to help you do this. Now, of course, we could only use the tools that WHO have, but you may well have tools that you heard earlier in the last talk. There are many tools developed locally that you can use to ensure that you engage children and parents. Then they have to look at the environment. The talk one but last was on the environment. So we have to look at the environment and see how it works, and so it fits in with that talk. Then we have to see how we organize the work and how we do this together. And finally, we have to have some measures. PREMS, patient-reported outcomes, experience, and patient-reported outcomes. So this is the example. So you can see it's all based on human factors. And now I'm asking you to start thinking, if I'm going to commit, which of these would I start with on number one? Goal number one is how we engage children and young people and their parents. And just to say where you can also look for some inspiration, these are the Patient Safety Rights Charter. We wanted to do a Children's Rights Charter, but it's not in WHO documentation yet. So we've done one so I'm putting the one for adults, which applies to children. And these still apply, that you need to think. This is from the campaign 2 years ago. So being people focused. The next one is enhancing medication safety. As you know, medication safety was a major focus at WHO. And this one is obviously the second one we put in because it's the first major harm that happens to children. About 40% of all harm is medication safety. And here you've got to talk about people, the patient medication literacy. So you can see we start still with patients. Now, these are, as you can see, they're all cross-cutting. It's just convenience to have 5 goals, but they're all cross-cutting. Educating parents on safe medication use, training the healthcare workers. Here's the tasks, the full details. Prescribe only necessary, double check all high-risk medications. The tools that you need, dilution charts, electronic prescribing if you can get it. Decision support tools, the environment with no interruption zones, well-lit areas just for prescribing, how you organize it, using medication without harm challenge, monitoring, and then, of course, the measures. So there's enhancing medication safety. Once again, you may wish to choose one of these that you want to commit to. Diagnostic safety is a major risk in children, mainly, as I told you, because of the 4 Ds. They change over time, they cannot speak up, and the epidemiology changes, and often things are masked, particularly in sepsis and in deterioration. So here we get to know the age-specific vital signs and presentations. These are so important. Keep misdiagnosis in mind. Always ask, could it be something else? And you heard in the previous speaker, seek second opinions for complex cases. So important. They're the tasks, age-appropriate histories, structured differential diagnosis, some of the tools you can use, checklists, technology, or building on what was said in previous talks. Again, the work environment, how we design the work environment in order to make it safe, and then how we organize our care. Blame-free culture. Jackie spoke about the absence of blame-free culture for reporting errors. Well, that's so important because we need these to be reported. And then finally, the measures that you can take. Later this year, the WHO will be publishing the advisory document from last year's campaign. This year we took a different approach. They took the approach they wanted at a more forward-looking ahead of time. So this is the measures are going to be more wider once that document has come out. Goal number 4 is preventing healthcare-associated infections. That's the number 2 of the harms that happen to children. Again, there you look at, you heard Jackie talk about the nurse-patient ratios. That's so important to decrease healthcare infections. Annual training and the role of parents, involving parents in care, and that's with Kangaroo is very important. You'll hear in the next slide. Here are the tasks, some of the tasks on hand hygiene, on PPE, aseptic techniques, and very important, the structures in most lower middle income countries is often a challenge with waste management, water and lighting. And so we've got to address how that can be dealt with. And again, there you can see the work environment, designing spaces so there's not overcrowding for infection. That's so important. And here you have some of the surveillances, how we organize all of this together. And once again, some of the measures. These are just suggestions. Of course, what I've done on these slides is just giving a summary of what's in the document. So when you look at the document, there's far more to look at. So it's so important that you look at the document to see all of the things that we recommended. This is just a highlight view of what you need to do. And then finally, the risks for the small and sick newborn. And here we look at that you need people who have neonatal skills, because newborns are very different from children. And so you have to involve parents as part of the care team. That's so important. And if they're part of the care team, they feel involved, particularly if they're in the neonatal intensive care or high dependency. And so important. And so it's really try to keep your neonatal nurses in their roles. And I know often the problem is that the upper income countries steal the neonatal nurses from the lower middle income countries, and that's caused a major problem in a lot of the areas in the world. I know that's a problem in Africa and in Asia as well. Here are the tasks. This is really what you have to do, assessments, early at risk, early identification. This starts in the antenatal period and the perinatal period as well. And breastfeeding and early colostrum. That's so important. That goes and decreases infections. So getting the baby onto the mother's breast, and that's about kangaroo management, is so important. Here's the tools that you might need, that you might have. I'm particularly interested in decreasing maternal death and early child death and stillborns, and that's by having good processes in your obstetrics unit as well. And here you can see some of the environmental factors that we write, private areas for kangaroo and person-centered care. And then you have your organization. So you can see the human factors we've done, and finally the measurements for health with newborns with infections, preterm mortality, etc., etc. These are some of the examples. So I've just given the high-level examples, and you now need to do it. So I want you to think, once again, which goal, where you work, which one do you want to do, and you're going to download the book, the actual goals from WHO website, and then you can see, because this is not a WellPro Safe in day for one day. It's a call to action for the future. But just remember, at the end of the day, culture eats strategy for breakfast. So if you have the wrong culture, whatever your goal is not going to work. So we first got to say, we go to work, and as Jackie said, no one gets up today to go and say we go to work to harm people. However, we've got to make patient safety our business. When we had comparisons with aviation, they fly planes, but safety is their business, not flying planes. It's have to fly planes, but safety is their business, because no use flying planes that crash. So they have to have safety. That's the first thing. They may lose your baggage, but no, safety is the most important thing. Not the food you eat on the plane, but whether the plane is safe or not. And that's why if you fly on a plane, you need to observe all the safety things they're doing. You see them when you look for them. They're doing safety all the time. Little things that you just take for granted. Likewise, we need to do that now and say safety is our business, and there's a roadmap we have given you in the goals to make it safer for young children and newborns. And I always like to use a Mandela quote, because you might think this is all impossible to do, but Mandela said it always seems impossible until it's done. So if you start now, you'll make a big difference. So it's time to commit. BK, get everyone to write in the commitment into the chat. It's time to commit. And I thank you for listening to me today.
Thank you, Peter. Thank you very much. Wonderful as always, bringing us the latest updates, what's going on globally, particularly from WHO and organizations who are working very hard for patient safety. And your insights coming from the experience of hardcore experience in clinical area as well, not just philosophical quality, brings us a lot of value, which gives us a lot of confidence in the work being done. So thank you so much, Peter. And I'm sorry to disturb you early morning, but we thought that people will get real good insights from the horse's mouth. We say, coming from the practical and theoretical approach combined with the experience which we gain over last several years, make the life of patient better, safer, and whatnot. So thank you so much once again. So as Peter asked everyone to write down what is your goal at the end of the day, until we commit to ourselves. You need not to commit to someone else, but to ourselves. That yes, this is what I will be doing in next 1 year, for example, and I'm committed to do that. I think that will make a great difference in the lives of patients. So I think if you are really committed, and I think these people who are staying there committed towards that, I'm sure, and I'm sure you have take-home messages from all the speakers coming from different backgrounds and different part of the world, sharing different topics and aspects of patient safety. Thank you, each one of you, and we would be very happy to see you again sometime. And thank you all the speakers who could take their time out for this webinar. Thank you very, very much. And we look forward sometime. And Peter had put something. I think he has put some article.
Yeah, put the goals in the chat.
Yes. So this is how he has put that the whole document coming from WHO, Patient Safety Goals 2025, basically dedicated for newborn and every child. Beautiful document. You can read and start, not just read, start implementing, practicing in your own practices and organizations. Thank you very much, everyone. And with this, I think the time to come to close this webinar. I'm sure little delayed, so apologies for holding you back for at least 38 minutes as we put the time in. But nonetheless, this has been very, very beneficial and productive for me personally, I'm sure for my officers and everyone who have been attending this webinar. with this, thank you once again and see you sometime soon. Have a great day ahead, everyone. Good evening, good afternoon, wherever you are in your different time zones. So thank you very much, everyone. Take care. Thanks, Jackie,
Bye.
Aminul, Peter. I think these two
Bye.
speakers stayed. Thank you. Bye-bye. Take care.
Thank you. Bye-bye.
Bye,
Bye.
Jackie. Bye. Bye.
Bye-bye.
बंद करूं?